strengthening exercises. Good sleep, good brain. So prioritize quality sleep because sleep clears brain toxins and consolidates memory. Aim for at least 7 to 9 hours of sleep every night. Stick to a schedule, limit screens before bedtime, and also limit screen time. Create a sleep-friendly environment. Say no to stress so the brain doesn't fuss. It's important to manage stress because chronic stress can shrink parts of the brain. So we need to practice meditation, deep breathing, journaling, nature walks, and have good friends for good laughter and great friends for great laughter. Learn and learn so the brain doesn't yearn. Keep learning because learning stimulates new connections and enhances neuroplasticity. Read good books, read more books, learn a new skill or language, solve puzzles, play brain games. Just keep the brain going. Social life is brain health. So stay socially connected. Social interaction helps cognitive function and mental health. Maybe call a friend, join a club, volunteer for activities of your choice. Just keep connected. Say no to harm to keep the brain's charm. Say no to smoking, no to alcohol, no processed foods, no excessive screen time, the need of the hour, no isolation, and yes to socialization. To summarize, eat well, eat good, exercise, sleep enough, manage stress, learn something new, and stay connected. So, final thoughts and call to action. Let's start small, one habit at a time, because brain health is a lifelong investment. Your brain is your greatest asset. Treat it that way. Thank you.
Thank you, Dr. Hita, for briefing on this brain health. To begin this occasion on a serene and positive note, let us invoke the blessings of the Almighty. Now I invite Shilpa Shri and Sushmita Garu to present the prayer song. Please welcome with a big round of applause.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि गानचतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानवत्साय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यकलाक्षेत्रे गुरुधर्मसदाराध्याय गुरुपुत्रपरित्रात्रे गुरुपाखण्डकण्डकाय गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्साय गोजयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय बालचन्द्राय श्रीगणेशाय धीमहि
Thank you for the melodious song. It's my privilege to invite the dignitaries onto the dais. Now I request Shri Mr. Radha Krishna Garu, Joint Director, ESIC Rayalaseema Zone, to please come onto the dais. I request Shri Dr. R.R. Reddy sir, President of Indian Medical Association, Tirupati, to please come onto the dais.
I would request our honorable guest, Shri Mr. Radhakrishna Garu, Joint Director, ESIC Rayalaseema Zone, to please take the small token of gift.
I would like to request our beloved head of the department and senior consultant, Dr. Anand sir, to please come onto the stage. I'd like to request Dr. Rama ma'am, Managing Director, renowned sleep medicine specialist and neurologist, to deliver the welcome speech. So please let's welcome ma'am with a huge round of applause, please. I would like to call Dr. Vijayendra Reddy sir and Dr. Ashwin sir to please, please stand on the dais. Please. Please give a big round of applause, please.
అందరికీ నమస్కారం. I'd like to welcome everybody. I'd like to welcome everyone to the Neuro Conclave. In particular, R.R. Reddy Garu, President of IMA. Sorry. Shri Radhakrishna Garu from ESI Director. It's a really proud moment for me today to present, to start the Neuro Conclave. Being a neurologist myself, quality neurology services has always been very important to me. And it's a big job to fill because I come from Northwestern University, where we had a very superb neurology department with the neurocritical ICU, neurointerventional radiologists, neurosurgeons, as well as neurologists and neurocritical care specialists. So when I came here and I was all alone, I was really worried about how we'd bring similar resources here. But we have a great team of doctors, starting with Dr. Anand, our neurosurgeon who joined us, and Dr. Yashwant. First day after Dr. Anand joined, we were able to take a police officer who, in the line of duty, sustained a very severe head injury. Almost within 1.5 hours of entering our emergency department, we were able to wheel him into the OR after completing the CT scan and basic workup. And Dr. Anand was successful in saving the patient, a very bad trauma. We also have a very superb neurology team, and Dr. Vijendra Reddy is only one person, but he's working like 3 people. It used to take 3 of us in Northwestern to do the work that he does. The support he gives both is an outpatient department, inpatient department, as well as the neurocritical ICU. Dr. Anand, the head of the neurocritical ICU, our wonderful anesthesia team and emergency department, and that support. So definitely, going forward, this is one area that we really want to develop, and it makes me proud because neurology is very special to me. And also the concept of pre-hospital care and being able to diagnose and initiate treatment within the ambulance itself, which in turn is very important, getting the right doctors in place, giving the basic first aid on the way to the hospital, whether it's acute stroke or head trauma, and whatever the situation is. So with that, again, thank you all for coming, and I'd like to give the mic back to the organizing committee.
I would thank Dr. Ramadevi Gourineni Garu for doing the honor. Thank you, ma'am. Deepa Jyoti Parabrahma, Deepo Jyotir Janardhana, Deepo Haratu Me Papam, Deepa Jyotir Namostute. Such is the power and prowess of light. I would now request all
I'd like to ask Shubharati ma'am to please join. And I would like to call Dr. Radhika ma'am, Vijay Nirmala ma'am, and Sunita ma'am to please Shalini ma'am, sorry. Shankar sir to please join. And Namita ma'am, please. I would like to call Dr. Vinod sir to please join. I'd like to call Dr. Rakesh sir, Shivaram Krishna sir to please join. I thank all the dignitaries on the stage for lighting the lamp. Now I would like to request our Honorable Chairman, Dr. Prasad Gourineni sir, to felicitate our guests, Shri Mr. Radhakrishna sir, Joint Director, ESIC Rayalaseema Zone. Please give a big round of applause. Thank you, sir. Now, I would like to request our Honorable Chairman, Dr. Prasad Gourineni, sir, to please felicitate Shri Dr. R.R. Reddy, sir, President of Indian Medical Association, Tirupati. Please give a big round of applause.
my privilege to welcome our chairman, Dr. Prasad Gourineni Garu, internationally acclaimed orthopedic surgeon and hip preservation specialist, to address the gathering. We welcome you, sir.
Please give a big round of applause, please.
Well, welcome everybody and thank you for coming. Where's my talk, guys? Right below that. All right. Again, welcome again. My objective today, how do I advance the slides? Sure. So my objectives today are to introduce Amara. Some of you think that you know Amara, may not know what I want to say. Show you what and how we do things. And it's a call to collaborate, both for doctors and non-doctors. We want to work together. Amara Raja, Ramchandra Gala, mother of Jaydev Gala, the two-time MP, and chairman of Amara Raja right now. But more importantly, she's a lady, a people's leader. R.R. Reddy Garu knows her very well. She's a minister holding several portfolios in Andhra Pradesh government. Right? She's the inspiration. If not for her, this hospital won't be here. Of course, Ramchandra and Gala, the founder chairman of Amara Raja, who built all Amara Raja, has built this hospital too. So what brought us from USA, Dr. Ramadevi and me? The purpose. We learned some in America, saw a lot in India. We thought that we need to combine the best to be really help people. The goal or promise to people, ourselves and to the people, is ethical practice, which you all know how we do in Amara, right? Always ethical. Our strategy is not competition. We don't look at anybody else. Collaboration. Let's work together to help more people and grow together. And my dream, of course, someday is universal access. Don't worry about money. Just take care of everybody as they come, right? So, treating people, one of the important things is emergency health care, right? We always focused on that. I would say that the best part in the hospital is our ER. You all probably should tour it. People haven't seen this. It can't be any better than our emergency room anywhere else, right? So the important thing with emergency care is the golden hour. You know, the first hour after trauma. And if people are going to Chennai and Bengaluru, they're not going to get the treatment in the first 1 hour. It's very important to get that treatment early in their backyard, in their home. So Tirupati population, to get it in Tirupati area, right? That was the focus for us. And once they come here, one stop for all. They shouldn't have to go anywhere else, right? We should have all the specialities to support them so they don't have to be transferred again from here somewhere else, right? And one of our things is transparent care. I don't know if you noticed it. People are allowed to watch what we do, no secrets. Everything is transparent. We do what we need to do. So part of emergency care is having all the specialists on board, right? We have pretty much all the important specialities. Orthopedics, top-notch, cardiology is good, but today's focus is on neurosurgery. We have ENT, we have all the other specialities, including urology, but the focus from now, this point on for me is neurosciences, right? We built the facilities, we bought the equipment, but without the staff, the proper doctors and protocols, it cannot be an institute or a center of excellence. So Anand has come a long way, 1 year. He has done a lot of marvelous things. And Vijayanda has put up protocols, so we can say that we are in the process of going towards being a center of excellence pretty soon in neurosciences. Starting off with what we have and what we do. Like I said, I already bragged about our emergency department. A complete team of specialists available 24/7. There are 3 consultants always in the hospital. A senior anesthesiologist, a senior intensivist, not a junior, right? A senior consultant intensivist, and an emergency physician always on in the hospital 24/7. The ER boasts, we start off with the decontamination outside, then we have isolation rooms in the ER, we have trauma bay where we can do surgeries if we need to, and the facility is fantastic with support of X-ray, 128 slice CT scan, a 3T MRI right next to the ER, cath lab very close, and we have everything that's a ER doctor requires to take care of a patient. And of course, we have a very top-notch blood bank, right? I think we started this year or last year, I don't remember exactly, but we have very good blood bank, maybe best in the area, right? And again, if you want to come to the emergency room, you can see what we do. There's a family viewing area where families are allowed to watch if they have the stomach to watch what you're doing. These are trauma bay. These are 2 bays of 4. You see the ventilator there. We can actually, this is like an ICU room where we actually can do emergency procedures if we need to. The blood bank again is top notch, right? We brought Rotem recently because that's what the doctors required to resuscitate a patient accurately. Flexible endoscopy, the anesthesia team is quite good, and with neurosurgery, with neck trauma and head trauma, we may need to intubate without manipulating the neck and head too much, and this helps a lot. So 2025 highlights, right? We had 2 mass casualties that were handled very well at Amara. The first one was 50 to 60 patients, came within an hour or 2, and glad that we didn't have any major problems with them. They all recovered well and went home very well. The whole team of doctors responded. The way we handled mass casualty is we stopped the OT, we stopped the OP, all non-essential services were stopped, and everybody came to the ER to help the people. 50, 60 people, 50 to 60 were all taken care of in a timely manner. The second mass casualty was Amara Raja employees more recently. There was a smaller number, but the first experience made it better for the second group. So mass casualty is we train and prepare early on, treat them when they come, review what we did, we counsel people for the trauma they get from the mass trauma, right? And we follow community education. We prepare communities to prevent injuries and treat them early. New this year, our endoscopy and dialysis unit are coming up in a month or 2. Renal transplant program is approved, right? We are going to do renal transplants soon. We have a stem cell lab. Believe it or not, we have a stem cell lab with research. Dr. Visha Madhuri is heading it. We have a mother-baby unit now, separate for babies and pregnant mothers. Rehab unit is coming up. We converted one of the units to rehab now for long-term care. Medical tourism is part of our focus this year. And we have a prosthetic lab. We don't need to send anybody else for orthotics and prosthetics. We can do it in-house, right? We had an NABH review last week. We think that we did well, and we should be closing it pretty soon in a month. So we'll be NABH certified pretty soon. We initiated quality improvement measures. We have mortality and morbidity every month. We started a grand rounds, Tirupati-wide. We invite everybody in Tirupati to come for the grand rounds, right, and participate. Robotic arthroplasty started today. We have Mako, one of the best robots for orthopedic arthroplasty. Now come to neurology. We have 2 experienced neurologists on staff. Dr. Rama mentioned already about Vijayendra. He's a top-notch neurologist. We have all the equipment he needs, EEG, EMG. We have sleep lab in-house, right? He's finished a stroke program. I remember Anand asked me to bring these catheters that are 4 feet long, and a hand carried them from America, right? 4 to 5 feet long catheters. They don't fit in the overhead cabin, so I had to manipulate the personnel in the aircraft, right? So we have all the gadgets, like I mentioned. So with these long catheters from the groin up, our team can actually reach the brain and remove the clots, right, for stroke. Neurosurgery, 3 surgeons, headed by Anand. They're all trained to do it all. We do pretty much everything. I don't think there's anything Anand can do these days. Trauma, aneurysms, tumors, even arterial bypass to the brain. I don't know if he did any yet or not, but he can do it, right? Then we have dedicated OT. Anand likes OT number 4, that's dedicated for neurosurgery, and has a team that's dedicated also. He has everything he needs: navigation, high-end microscope with the fluorescent staining or something like that, right?
and the radiolucent tables. Whatever he wants, he has. So he can do pretty much anything at top-notch quality, no compromise. This is not OT4, it's OT1. I didn't have a good picture of OT4, but OT1 looks like this. OT4 looks about the same, maybe a little smaller. This is the microscope Anand is using. He's not sure if video plays or not. Using navigation to treat a tumor, right? He probably will share more of these videos next.
This is the post-op cavity.
A neuro ICU. Current neuro ICU is good, but the next one is going to be better, right? Single rooms, neuro-intensivist heading the neuro ICU program. He has whatever he needs. He has transcranial Dopplers, right? He has ventilator, dialysis, everybody has. CRRT is something we have that's useful for people who can't handle dialysis. And ECMO, we have some experience with ECMO already, and we are in the process of buying an ECMO machine full-time for our use. Here's an ICU that's coming up with single rooms. That's a bispectral index to evaluate the depth of consciousness and coma. Here's a transcranial Dopplers. Here you can see Anil with the patient. A CRRT machine, quite useful in people who cannot handle dialysis. ECMO machine. Neuro rehab. Ever since Anand came, he wanted to have a rehab unit. We gave him a makeshift one, but he's not happy, so we're making one permanent, really top class on 7 West. It'll be a rehab unit where he can handle tracheostomy, ventilator support, all types of therapy, and all specialties available to support those patients if they need anything else, right? All types of therapy. Lastly, understand that Dr. Rama mentioned a little bit. We call it Amara trauma system, but it's for all emergencies. Strokes and epilepsy and status epilepticus can follow the same system. We have Anand right now to head this program, Amara trauma system, where one phone call, you just call this number, 7699-108-108. It initiates care at the site, right? We're going to guide the people who are available with the resources to stabilize the patient at the site. We send the ambulance to that place, the nearest ambulance, not our ambulance, right? We have a chain of ambulances now. Get the patient on the way en route. Evaluate the patient, get an idea of what they need, treat them and stabilize them en route. As soon as they arrive, the team is ready for them. The OT is ready if they need surgery. And Dr. Rama mentioned 1.5 hours. It won't be 1.5 hours. It'll be more like the US time, 10 to 15 minutes as soon as they hit the door, that they get the CT scan and they go to the OT. That's how fast it's going to be for the golden hour. So this is how it is now with ambulances. And we have the facility on the rooftop, and someday probably we'll use a helicopter to do the ATS. So again, once again, I call all of you to collaborate. There's no competition here. We all need to work together, right? We can do more than what Amara alone can do. Let us help more people together. We'll grow together at the same time. Join the Amara family. It's Mana Amara, right? Use our lab, use our experts, use our facilities. At the same time, you can take those patients back. We're not going to keep them here. For continuity of care, take them back to your own practice and to your own hospital. We'll help you with whatever you need that you don't have, but afterwards it's your patient, right? And participate in our grand rounds. Come, listen, learn, teach, right? Thank you very much.
Thank you, sir. Thank you for the insightful address. Now I request Dr. Anand sir to present a memento to Dr. Prasad sir as a token of gratitude. Please give a big round of applause. Thank you, everyone. Now I request Dr. Anand sir to present a memento to Dr. Rama ma'am as a token of gratitude. Please, sir. Please give a big round of applause. Thank you, everyone. It's time for the most awaited segment of this enclave, the scientific talks. To begin with, to understand the pathology, first we need to understand the anatomy. And we have Dr. Radhika ma'am, critical care consultant, to simplify and unfold the complex neuroanatomy for all of us. I welcome Dr. Radhika ma'am to present her talk. Please give a big round of applause.
ಚೆನ್ನಾಗಿದೆ ಅದು ಫುಲ್ ಸ್ಲೈಡ್ ಬರಲಿಲ್ಲ ಇಲ್ಲ ಈ ಥರ ಬೇಡ ಫಸ್ಟ್ ಇತ್ತಲ್ಲ ಅದೇ ಥರ ಬೇಕು ಬರುತ್ತೆ
Good afternoon, everyone. I thank Neuro team for giving me this opportunity to speak regarding the basics of neuroanatomy. As the topic suggests, I'll try to keep the topic as simple as possible so that everybody understands it. Understanding our brain helps recognize early symptoms, improve the healthcare decisions, and support the well-being of the patient. Just I'm going to tell about the basic neuroanatomy, brain functions, and the emergency signs. Nervous system is divided into central nervous system and the peripheral nervous system. Central nervous system is formed by the brain and the spinal cord. Peripheral nervous system is the connection between the central nervous system to other parts of the body. Central nervous system will process the data and it will transmit the signals to the other parts of the body. What makes the brain, spinal cord, or your peripheral nervous system? It is the neuron. Neuron is the functional unit of the nervous system. It is made up of cell body, dendrites, and the axons. The information which is carried by the dendrites, it transfers to the cell body, from there to the axons to the axon terminals. From the axon terminals, through the synapse, it goes to the other neuron. In the synapse, there will be exchange of the signals. This slide shows some of the things which causes neuronal damage. Just like damaging wires can ruin a machine, things like accidents, drugs, alcohol, and diseases can ruin the brain cells. Let's look into this gross anatomy of the brain. It is forebrain, midbrain, and the hindbrain which forms the brain, and cerebrum, thalamus, and hypothalamus forms the forebrain. Forebrain is like a CEO of a company. It takes the information from outside world and makes decision, plans things, and tells the rest of the body what to do. Midbrain is the messenger between the forebrain and hindbrain. Hindbrain is like a maintenance team. It controls the basic life functions like breathing and heart rate. Brain is protected by the skull, and under the skull and between the brain there are the three protective layers, that is dura mater, arachnoid matter, and the pia mater. Between the arachnoid matter and pia mater there is a liquid present, that is cerebrospinal fluid. These will cushion and protect the brain. And brain is divided into, cerebrum is divided into frontal, parietal, temporal, and occipital lobes. Temporal lobes is involved in hearing, memory, and language comprehension. Occipital lobe is for visual processing and interpretation. And frontal lobe is for thinking, reasoning, memory, and all these things. Cerebellum is a small part at the back of your brain that helps with balance, posture, and coordination. In real life example, when you walk without falling, ride a bicycle and catch a ball, then that's your cerebellum is normal. If it is not working properly, you feel dizzy, fall easily, and have a shaky hands. Coming to the brainstem, it is formed by midbrain, pons, and medulla. Midbrain contributes to control of movements, whereas pons, it relays the messages together with medulla oblongata helps control breathing. Medulla has vital centers that regulate the heart rate, breathing, and blood blood pressure managing. Other centers coordinate swallowing, vomiting, coughing with the midbrain. Like other parts of the body which get blood supply, even brain has its blood supply. Circle of Willis is formed at the base of the brain. It is formed by the internal carotids and the vertebral artery. The circle of Willis is a safety ring of arteries that ensures that brain keeps getting blood even if one artery is blocked. Branches that supply the brain arise from this circle of Willis. Any block in that artery will affect the function of the corresponding part of the brain. Brain health tips, there are 10 health tips. We have to sleep well, stay hydrated, avoid head injuries, stay mentally active, as Hita has already mentioned. Now let's see the red flag signs of stroke, headache, and the brain tumor. Be fast is a simple way to remember the signs of a stroke. A serious condition where part of the brain does not get blood flow. There will be loss of balance, eyesight changes, face drooping, arm weakness, speech difficulty, and time to call the emergency. Snoop, it will help the physicians to differentiate between the primary and the secondary headaches, and it will help the doctors to figure out whether a headache is a warning sign of something serious like a brain tumor, bleeding, or infection. In these SE systemic symptoms like fever, weight loss, rash, or other symptoms, and N for neurological symptoms like seizures, etc. It will be sudden onset in older patients if it is progressive and if there is any positional change. Then it is a red flag for headache. And symptoms of brain tumor, early morning sudden headache with a projectile vomiting and decrease in the symptoms of headache after vomiting is an imminent sign of raised ICP. And any changes in mood changes, cognitive decline, speech problems, or seizures. These are the red flag signs for the brain tumor. Hope these basic topics help you in understanding the upcoming discussions.
I would thank Dr. Radhika ma'am for helping us navigate across the complexities of neuroanatomy. Now I would request Dr. Yashwant sir to please present the memento to Radhika ma'am. Thank you, sir. Thank you, ma'am. Let us think for a moment. How many hours in a day do we give our brain real rest? That is, the sleep and stillness. Because brain health isn't about activity, it's about recovery, it's about rest. And today we have one of the renowned experts in the field of sleep medicine in the country, that is our Dr. Ramadevi Gourineni Garu, to address the gathering about the importance of sleep and brain health. I request Madam on stage.
Services, and thank you for giving me the opportunity to explain a little of what I do. There's no particular subject matter. I just wanted to let everybody know what type of problems we see and what services we provide. At Northwestern University, I was not only a neurologist, but as a sleep specialist, Director of Neurology Medical Student Education, and Fellowship Director for the Sleep Fellowship Program. Sleep can't be practiced in isolation. We need a whole sleep team, including technologists that are trained. So a lot of what we do when we start a program, teaching is always part of it. So what are the barriers to treating sleep problems in any community? It's a lack of awareness of problems in the public. A lot of people, even if they have sleep problems, they understand their own sleep problems, but they may not understand that it's a medical problem, and there's actually people who will understand it. Or there's also lack of awareness among healthcare professionals. So even if the patient opens up and the doctor either doesn't take it seriously or is not able to properly diagnose it, then the patient may not open up again. And the family and the community, see, if you have a broken arm and you go to the doctor, even if you have diabetes, hypertension, heart problems, go to the doctor, it's acceptable. Many times having depression, anxiety, sleep problems, it's things that people can't see. So the community and the family may label them as crazy, histrionic, say, you're always going around doctors, why are you going again? Why are you wasting fees? So lack of appropriate treatment also. What happens when these problems aren't properly recognized and properly treated? This is a study done initially in Canada that showed the direct cost of treatment of sleep disorders, if they're properly diagnosed and treated, is $16 billion a year, which sounds like a lot. But what happens if you don't treat them? The indirect costs of not treating sleep disorders, including absenteeism from work, presenteeism, meaning they're present at work but not properly functioning, accidents. Like I said, most of the accidents that I heard about even at Amara, a lot of them, you have to suspect sleepiness-related accidents. So accidents, in particular, large vehicle accidents, morbidity, mortality associated with this, leads to $50 to $100 billion in cost. So we need to weigh the pros and cons of diagnosing and treating versus not diagnosing and treating. Next, patients with undiagnosed sleep disorders were shown to have a higher rate of utilization of healthcare services. So even though they're not going for their sleep, they're having multiple other problems. There's also many studies that show patients with chronic medical problems and sleep problems, if you treat the sleep problem, regardless of anything else you do different, the chronic medical problems also get better. There's a lot of inflammation and other problems associated with not properly sleeping that can affect other conditions. And sleep apnea, even though I won't talk about it, can also lead to hypoxemia, heart rate variability, hypertension, as well as inflammation at night. In the USA, 100,000 motor vehicle accidents annually are sleep-related when analyzed. So this is not the United States, this is India. It could be Karakambadi, Renugunta also. And disasters such as Chernboil, 3 Mile Island, Bhopal, and Exxon Valdez, all of these, you might have heard of them, were all attributed to errors in judgment relating to sleepiness and fatigue, especially during night shift, where there are certain parts of the night shift where the drowsiness is maximum. So understanding and recognizing these from a public health policy is also important. This is Bhopal. On a cold December night in 1984, Bhopal was struck by one of the worst industrial disasters, where 10 tons of poisonous methyl isonate gas leaked from the Union Carbide factory, killing 1,700 people, affecting 5 lakh. 5 lakh people suffer from the effects of the tragedy. They say many of the second and third generation children born with congenital defects, cerebral palsy, and even cancer. And this is one, if you look into the details, the time it occurred, I'm not saying sleep is the only cause of it, but sleepiness and lack of proper cognitive function during that time probably contributed. So what type of problems do we see in the sleep clinic? We see people with difficulty sleeping at night, difficulty sleeping at the right time, daytime sleepiness, discomfort in the leg and movement, snoring, difficulty breathing at night, and wake behavior in sleep, walking in sleep, getting up looking confused, kicking, screaming in sleep. International Classification of Sleep Disorders initially formed in the 1970s and later revised twice in the 2000, most recent, I think, 2014, I believe, divides the disorders into one is insomnia, which is difficulty sleeping at night, both acute and chronic, and there's also something called behavioral insomnia of childhood, limit setting, improper bedtime routine, circadian rhythm sleep disorders, people that have difficulty falling asleep at an appropriate time at night and difficulty waking up in the morning, advanced sleep phase where they feel sleepy very early and wake up clock-like at 3 or 4 in the morning, irregular sleep-wake rhythm that can be seen especially in chronically ill patients that nap a lot during the daytime and have constant awakening at night. Non-24-hour rhythm that every day the phase continues to shift. Sleep-related breathing disorders, including people who snore and stop breathing in sleep, including sleep apnea and sleep-related hypoventilation. Hypersomnia can be due to not getting enough sleep, having disturbed sleep, but there's also certain primary hypersomnia, such as narcolepsy, idiopathic hypersomnia, and Klein-Levin syndrome. Parasomnias, again, as I mentioned, non-REM parasomnia, such as sleepwalking, sleep-related eating disorder, and also REM sleep parasomnias, such as REM behavior disorder, which is dream enactment behavior, where the patient become very violent. This is especially important for neurologists because patients with neurodegenerative disorders, such as Parkinson's disease, may have REM behavior disorder. Or REM behavior disorder, idiopathic REM behavior disorder, may be preceded by a neurodegenerative disorder if followed long enough. Sleep-related movement disorder, restless legs where they have pain and feel like moving their legs, on other sleep-related movements at night. So what services do we offer at Amara? We diagnose all the problems that we mentioned. We able to evaluate and diagnose all of them, and it's important that they're properly diagnosed and not just put on a medication. There's indication for sleep studies, but not everything is treated with just getting a sleep study. And that's why it's important to diagnose, because all of them can be treated. There's treatment for all of them. We're offering online consultation, both new and follow-up. Patients with insomnia, it's really hard to diagnose and treat in one setting. And a lot of them come from far away, including Kadapa, Raichoti, and even other cities. So a lot of them, we do online follow-ups with them to help them get through and start to sleep again. Level 3 or home sleep studies we're doing. Level 1 and in-hospital sleep studies. Cognitive behavioral therapies, psychological evaluation, treatment, and we have specialty support in the hospital. So like I mentioned in the sleep clinic, we have the expertise to diagnose and treat all types of sleep conditions. Level 3 sleep studies are done at home. We can set them up here in our hospital, or we can come to the home. And this is a new service that we're organizing currently, Amara Home Sleep Services. And the advantage is it's less expensive, and a lot of times it's accurate enough to diagnose obstructive sleep apnea. The other thing is sometimes when we do the study in the lab, it's really difficult to diagnose and treat at the same time. So doing a level 3 study initially, home sleep study, is very helpful. If you see here, this is the patient's breathing and snoring. Here they stop breathing, and there's an oxygen desaturation that occurs over here. Level 1 sleep studies are more sophisticated. We measure the EEG and sleep. We also measure the eye movements as well as the chin tone so that we can score the stages of sleep. We record the breathing, the ECG, leg movements, and we can also titrate CPAP with this. Patients with comorbid cardiopulmonary disease must have a level 1 study, or at least for titration, the study needs to be level 1. Patients with parasomnias and epilepsy, if you suspect that they're having OSA, you can still start with the level 3 study, but otherwise they need a level 1 study or epilepsy monitoring. To do CPAP and bi-level titration, many labs do just auto titration even in the lab. Our lab, our technologists are trained, and I'm able to guide them through the night to do actual titration using American Academy of Sleep Medicine protocols. So here, the difference between the level 3 and level 2 is the EEG, ECG, leg movements. We have a camera that's video locked with the recording. So if a patient does something at night, we can go back to the exact time period in the study to see. Technologist is there throughout the night. We don't just hook them up and leave. There's somebody there all night watching them, helping them, correcting artifact, and also titrating. So this is a level 1 study where we see the EEG. Level 1 sleep study, we have standardized protocols and can do titrations and are able to assist the patient if they sleep in the lab to get used to the CPAP and BiPAP titration treatment. We also do MSLT, or mean sleep latency test, which is done when we're evaluating primary hypersomnias. This is daytime nap test where we give 5 nap opportunities to diagnose primary hypersomnia such as narcolepsy and idiopathic hypersomnia. Once CPAP and bi-level is started, selling the equipment is easy, but monitoring the patient, looking at the download data, and making sure, seeing how long they're using it, and if they're not using it, what is the problem? Is it nasal congestion? Is it that the pressures aren't enough? We do all of that, so we can see this. Once the home sleep services start, we can do this even from their home to guide and monitor the progress of their treatment. CPAP education is really important. More than the sale, it's getting the people to understand how to put on the mask, how to clean the ventilator, how to clean the mask, and how to check for compliance. Many patients have claustrophobia, and we have a desensitization program, including our psychologist who helps them. Problems with nasal congestion is often ignored, and treating the nasal congestion can help them tolerate better. We also do cognitive behavioral therapy. We have a psychologist that works with us. She can do cognitive behavioral therapy for depression and anxiety, but cognitive behavioral therapy for insomnia is, even though it's the same principles that we follow, their guidelines are different. And before starting any medication, we try cognitive behavioral therapy first. Sometimes we may start a small dose of a medication first along with it. But medication tapering is also important. A lot of times patients come to us on 3-4 medications that they've tried, and they may still be using, especially benzodiazepines. High doses of benzodiazepine and escalating the dose can lead to multiple problems, including rebound anxiety. We take part in tapering these medications. The help that we have from our experts is Dr. Arunraj, who's a pulmonary critical care specialist. Whenever they have underlying pulmonary disease, overlap syndrome, and other problems, it's very helpful. Sleep medicine is not a one-person job. It needs multiple doctors to work together. ENT, Dr. Khalil, when patients have chronic nasal congestion and upper airway obstruction, he's very helpful. We also send patients to Chennai when they need upper airway surgery for snoring-related surgery if they don't have significant sleep apnea. Maxillofacial surgery for facial defects. Even though we send out for oral appliance therapy, there's many conditions such as overjet. micronathia that can be treated surgically, and we can repeat the study to see if the sleep apnea has resolved. But more than just the sleep apnea, there's other advantages of these surgeries also. In our sleep team is myself and Dr. Anupama, Tahir, and Mamata. Mamata is our sleep nurse who's been training with me, conducts overnight studies, as well as helps us with behavioral therapies in the sleep clinic. And our new team members that we're teaming up with to start the Amara Home Sleep Services also. Thank you.
It was indeed a very insightful talk on the importance of sleep medicine. Thank you, ma'am. I would now request Dr. Vijayendra Reddy, consultant neurologist, to address the gathering and tell us what's new in neurological disease management.
Before I start my talk, I would like to welcome Dr. Ramesh Chandra, the HOD of Neurosurgery of SWIMS. Please, welcome, sir. Thank you, sir. So, when the discussion about having a talk, I thought, what should the title of talk be? Because neurology is pretty vast. So I thought we'll see with what's new in neurology in the past 10 years at least. So I posed this question to a ChatGPT agent called Perplexity, and these are the answers which I got. So basically there's advancement in genetics, there's advancements in neuroimmunology, there's development in stroke care, and there's development in epilepsy along with imaging. Let's see how we at Amara are doing among these categories at least. So we'll start with stroke management now. Why I'm starting with stroke management is at least 50% of patients that we get, both inpatients as well as outpatients, are stroke patients. So the central circle is obviously where we are right now. The circle after that is approximately 1.5 hours away from where we are right now. The last circle, final circle, is approximately 3 hours from where we are right now. And all these patients who have symptoms of stroke are clearly vulnerable to treatment. So as soon as they have symptoms, they reach the hospital, they're seen by a doctor in the ED, they get a brain scan done, they either undergo thrombolysis or mechanical thrombectomy. So let's start with an example. Before that, let's start with some basics for the general public who is here. A stroke can happen in one of two ways. So you can have an artery which is blocked, and when there's clot in the artery, there's death of brain tissue. That is called an ischemic stroke. This is approximately 80% of all strokes that happen. You can have a ruptured artery where there's a bleeding and there's hemorrhage that also causes damage to the brain. So why is this important? In the bottom slide, we have the cerebral BV, which is the core. The core of the infarct, as time progresses, gets worse and worse. That is, the red color gets worse and worse. And the top, you have the cerebral blood flow, which gets worse in the darker colors. So the mismatch between the core and the CBF is what is called the penumbra. We are trying to save the penumbra as time progresses. And this is entirely why interventions as thrombolysis and mechanical thrombectomy are required. So how do we image the vessels? The are three major pathways. One is we do a basic MRI and do an MR angiogram. It's much more safer, more informative. The problem is if the patient has any metallic implants, you can't do it, and it sometimes overestimates the stenosis. On the other hand, we can do a CT angiogram, which is rapid, gets done within a couple of minutes, more accurate. The only problem is if the patients can have contrast-related reactions, so we can't give it to all patients all the time. The gold standard is something called a digital subtraction angiography, which we do here. Only thing is, if the patient actually requires any mechanical intervention, that we go ahead and do it in the primary place. So what we see here are the major arteries of the brain. The upper half, you can call it the anterior circulation. That corresponds to approximately 80% of the strokes. The posterior circulation corresponds to approximately 20% of strokes. Again, the ratio is 80% of ischemia and 20% of hemorrhage. So we see an example here. Let's see what practically happens. We have a 25-year-old male. This patient came to us from Rajampeta. The onset of stroke for him was at 11:30 a.m. in the morning. The patient and us were able to recognize the symptoms. They got to us at ER at 2:05 p.m. in the afternoon. The NIHS, which is the stroke scaling system, The maximum score is around 42. The patient had a very small stroke. NIH is only 3. The MRI starts at 2:20 p.m. The MRI gets done at 2:37 p.m. Is thrombolized with tenecteplase at 3:12 p.m. So we are able to thrombolize the patient approximately 65 minutes after the presentation to the hospital. This time is called the door to needle time. Now shift the patient to ICU within an hour. This time this patient's stroke unfortunately worsens. The NHS climbs up to almost 20. So what do? We don't sit quiet. We take the patient for CT angiography. We do the CT angiography. The CT angiography is done. And then we find that the CT angiography is patent. So then the score comes back to 6. So let's look at some images. This is an actual diffusion weighted imaging. What we see is looked around in the arrow is a small infarct as soon as the patient comes to the hospital. The arrow pointing here is showing the narrowing of the artery on the left side. That's where the clot is. Okay. Here we are doing something called a CT angiography on the left side, where we give contrast and we see the blood vessels in the brain. This is a reformatted CT angiography we are seeing on the left side, seeing that even though there is narrowing, there's good amount of flow happening distally, which means the artery has got opened up and the patient hasn't recovered. So we'll have two parallel examples here. On the left, we have a patient who underwent IV thrombolysis with tenecteplase. This is a patient who I talked to, an example, the 25-year-old male. He has very minimal deficits and very small area of damaged brain. We had a similar patient, a female, who came to us in the same month, came to us 6 hours after the onset of stroke, and this is how big this stroke is. So this patient is going to take a lot of time, 2 or 3 months for recovery. So if somebody has any kind of stroke symptoms, please come to hospital on time. That can be a difference between staying and walking, like this patient is able to do. So this patient is walking 24 hours after IV thrombolysis, independent, no hand weakness, no leg weakness, normal language. And it's not just one example. So I can show you one example of one patient getting better. And this is the data that we have. In the past 2 years, we did an audit. The median door to needle time is 68 minutes. Irrespective of whatever time you come to the hospital, irrespective of whatever symptoms you have. We have also done thrombolysis for patients out of window period, where we have diffusion flare mismatch. So take home message here is time. Time is very important. Our times, the median door to needle time was 68 minutes. The door to imaging time is 26 minutes. Of course, we obviously had complications. We had patients with ICH, but none of them were very symptomatic or required any kind of decompression. So in the past 3 years, we have been able to thrombolyze more than 45 patients, and all of these patients are doing well. The unfortunate thing is, this is still less than 10% of all the patients who have had stroke have come to a hospital. This needs to increase. This needs to become at least 30 or 40 or 50%, and all these patients will inevitably do well. Okay? So typically we are taught that when you hear hooves, you think of a horse, don't think of a zebra. The medical zebras are supposed to be rare or uncommon, but if you think clearly and do proper workup, we are going to find a lot of zebras. So let's see some examples. So we have a patient who is a 70-year-old male with chronic kidney disease who comes to the right upper limb and lower limb weakness, and the CT scan shows a right thalamic bleed. So it's obvious, I think most even general public know that you have a brain damage on the right side. We think that the patient's weakness is going to be on the left side. So what's happening here? This patient has a bleed on the same side and weakness on the same side. So we do an MRI, we see what's happening here. This is an actual diffusion weighted imaging. So what's happening in the brainstem is just an artifact. We see the bleed here in the right thalamic region, as confirmed on SWI, T1. We see the entire corticospinal tract. There's no other damage anywhere from the cortex, thalamic region, periventricular region, or the brainstem. We check the spine. There's nothing in the spine as well. So what is happening here? This patient has a rare thing where the corticospinal tract has not decussated at all. So the cortex on the right side is entirely coming on the same side. The bottom image is showing what is supposed to be normal. The top image is what is there in this patient. So this is pretty rare. Less than 50 patients have been documented worldwide, and we have probably the 51st patient here. It's usually associated with congenital clinical syndromes. So in acute conditions, ischemic stroke, bleed, or whatever, a corticospinal tract pathology should always be considered in case of discordant findings. And we do something called an MRI DTI, which we have here, diffusion tensor imaging. Another common complaint just seen is patient coming with headache and stroke. So we have a patient here, 35-year-old male, presenting to OPD with chronic headaches. These headaches have been there since the past 3 to 4 years. He's not very bothered about them. He comes to our ER with left side weakness since the past 4 hours, blood pressure of 190/100. My first initial reaction is this patient must have had a bleed. But then I asked the family history. The patient's father also has suffered multiple strokes in the past. So let's see what's happening to this patient's MR. So this is a sagittal DWI based imaging. You see this patient has multiple strokes all over the brain. He has cerebellar strokes, We have thalamic strokes, we have cortical, we have subcortical. You have basically strokes everywhere. Whatever is seen in white are all damage to the brain, which are the strokes. So now why will somebody at this age have so many strokes? We see that this patient also has bleeds everywhere. Whatever is in black are all the bleeds. So we have a patient with both a clot as well as a bleed. This suggests something called arteriopathy. That is, the arterioles are not functioning very well. So we have here white matter tract bilaterally significantly damaged. We have temporal lobe involvement. We have brainstem involvement. Again, actual image showing brainstem involvement and anterior-temporal involvement. So this, for any neurology residents here, is a classical syndrome called CADASIL, cerebral autosomal dominant arteriopathy. Again, genetically mediated stroke, less than 1,000 patients documented worldwide, and we have confirmed this with genetics. So we do genetics here for every patient which is appropriate. We take the clinical history, we find the appropriate phenotype. Again, we have a patient here with adrenoleukodystrophy, again white matter disease, again heritable, again potentially treatable. We again have patients with limb-girdle muscular dystrophy or any kind of muscle disorders where we do genetic testing. This entirely skips the need to do any kind of muscle biopsy or nerve biopsy anytime. So that is part of history right now. So you have patients with epilepsy as well who require genetic testing. We have patients with lissencephaly. This patient had refractory epilepsy, one has advised functional surgery. Now it's not just a matter of doing genetic testing randomly. If you just do genetic test randomly, you're going to find some tests like this. You find multiple genes being abnormal, you don't know what is right or what is wrong. So you need to have the appropriate clinical phenotype and test appropriately and see which disease needs to be treated. Finally, we have some neurological emergencies, status epilepticus, infections, neuromuscular emergencies, JB syndrome, dementia disorders, encephalopathy. I'll not take much of your time. A few examples. Convulsive status epilepticus is an emergency. You have treated more than 50 patients with convulsive status epilepticus and not a single patient has had any mortality. So persistent seizures for more than 5 minutes or multiple seizures without coming back to the baseline. We have multiple etiologies here. We have treated some uncommon etiologies of status as well. Hepatitis A, cyanide poisoning, autoimmune encephalitis. So I'll give you one example where a patient had prolonged superrefractory status epilepticus. That is, the patient had status for more than 1 week duration despite being on anesthetic agents. So this was a 19-year-old male, no prior comorbids, brought unresponsive to the ER, GCS of 3 out of 15, pupils not detected to light. In fact, the only way to find out the patient was alive was to hook up the main monitor and see whether the patient had blood pressure or not. So day 0, patient is intubated, status protocol followed. Still there's no improvement. We give anesthetic agents, we give IVIG, we give steroids, no improvement. Day 4, we check for everything, we check for autoimmune, we check for all viral markers, all of them are negative. Finally, on day 8, the patient gets extubated. This time the HSV PSR test comes positive. But all the meanwhile, we're able to still treat the patient appropriately and have a good outcome. Day 19, the patient is discharged. We'll see the patient's testimonial downstream. So this is the EEG when the patient comes to the ER. In the bottom, you can see the time. This is 4 hours after the onset of patient coming to the ER. We can see the small spikes which are starting in all the leads. This is a patient's EEG around 14 hours after the onset. So for somebody who doesn't know EEG, all these are epileptiform spikes and these are generalized spikes, which means the patient is having an active seizure. So we also check the transcranial Doppler parallelly to see if the blood flow to the brain is appropriately monitored and seen or not. So finally, after almost 17 hours, we achieve something called burst suppression. This is where we are able to actually control the seizure appropriately. Again, almost 31 hours later, this patient is back to a normal EEG, not normal clinically. Patient is only the EEG is normal. Still, we are supposed to treat him. We give him IVIG. We give him we try plasma exchange as well. Finally, this is the actual image of MRI on day 7. The first MRIs and CTs were all normal. We find little hyperintense lesions on right as well as left temporal lobes. This patient finally turns out to have herpes encephalitis. So typically, herpes encephalitis has a mortality rate of more than 40 to 50%. Despite the test not being positive, we treated the patient appropriately, and this patient is doing normal 3 hours later in follow-up. So we have again other rare causes of autoimmune encephalitis, which is Hashimoto's encephalopathy. Now it's been renamed as steroid-reactive encephalopathy autoimmune SREAT. Finally, demyelinating disorders. We have MS, MOG, as well as NMO spectrum disorders. This is a patient having right periventricular lesion. This is a radiologically isolated syndrome. A different patient whose MR is done, showing multiple lesions which are perpendicular to the ventricle and as well as corpus callosal lesions. This patient had a very huge longitudinal extensive transverse lesion in the cervical cord. This patient came to us with 0 power, was in the ER, was in the ICU for more than 1 week to 10 days duration. This patient finally was treated with rituximab. And this is the patient 3 years later, walking normally, independently, without any deficits at all, and had no kind of complications. One more patient, contrast enhancing lesion in the optic nerve, no brainstem lesions, no thalamic lesions. We have one lesion which is enhancing in the spinal cord, again a rare entity, MOG disorder, less than 100 patients diagnosed worldwide. So we are able to treat both rare as well as standard conditions. Thank you for your time.
So time is brain. The more time we waste, the less brain we save. Thank you for reinforcing on this important topic and introducing us to some of the rare things in neurology. Now I would request Dr. Shankar sir to present the memento to Dr. Vijay.
Thank you, sir. Now, I would like to request Dr. Rakesh, sir, consultant anesthesiologist and an expert in managing difficult airway, to address the stage and let us know regarding the anesthesia preparedness of neuro and spine surgery. Please welcome, sir.
Good evening, everyone. Myself, Dr. Rakesh, consultant anesthesiologist. Today, I will not take much time. I will just give a brief idea about anesthesia preparedness for emergency and elective neuro and spine surgeries. And why do we need to be prepared for all these surgeries? Because they are complex surgeries involving critical organs like brain, spinal cord, and the surgeries last for long duration. And what are the most common indications for emergency neurosurgeries are head injuries, trauma like SDH, EDH, intracranial hemorrhage. And what's our main goal? To optimize patient safety and outcomes, and proactive and systemic preparedness is vital. Coming to preoperative vigilance, prior to surgery, like anesthetic assessment is important, especially for neuro and spine cases. We need to look for existing defects, any ICP concerns, seizure history, C-spine stability, and airway challenges. And in general, as such, patients poses to have multiple other comorbid conditions, cardiac, pulmonary, and medication history needs to be taken. Either patient is on antiplatelets or anticoagulants. Here our goal is to identify risk and optimize the patient status. What are the equipment, drugs needed for emergency surgery? Like essential tools, standard and advanced monitoring, including arterial line for invasive blood pressure monitoring, central venous catheter, temperature monitoring, and rapid infusers for fluid infusion. And airway, full range, difficult airway cart, including video laryngoscope and fiber optic bronchoscope is needed. And basic drugs related to anesthesia for providing safe anesthesia. And availability of blood products, including tranexamic acid, is important. Coming to elective neurosurgical case, this is a model picture where you can see lot of equipment and lot of manpower are needed for a standard regular neurosurgery. Examples of complicated neurosurgeries are skull-based tumors, AV malformations, and posterior fossa lesions. These surgeries are of long duration and potential for major blood loss. So we need advanced airway planning and hemodynamic monitoring is needed for these patients. In the similar way, spine surgery poses issues in different manner, like long duration surgeries and involving prone positioning and significant blood loss. And these are few of the intraoperative neuromonitoring methods which we follow during complicated neurosurgeries: SSCP, MEP, EEG, EMG, and brainstem auditory pathways and BIS monitoring to monitor the depth of anesthesia. These are the various points where we target and monitor during surgeries. And coming to surgical positioning, you can see here these are the various positions we choose to do depending on the surgery. Either supine, prone, lateral or B-chair positions, and each position has got its own complications. Like prone surgeries poses definitive risk for the airway and pressure points like pressure on the eyes and hemodynamic fluctuations. In sitting position, B-chair position, chances of venous air embolism risk is high and orthostatic hypotension and cerebral perfusion is impaired. In lateral or supine position, general pressure care and nerve protection is mandatory. In all these cases, meticulous patient setup, continuous checks and prevention of complications is needed. And in coming to trauma, along with neurosurgery, patient gets this maxillofacial traumas, and this poses a greater challenges for anesthesia, especially maintaining the airway. Anatomical distortion and severe bleeding or secretions, limited mouth opening and cervical spine injuries are major concerns. So what are the strategies to manage such cases are awake fiber optic intubation is often gold standard and preserves spontaneous breathing, either video laryngoscope or surgical airway in case of cannot intubate and cannot ventilate situations. What are the intraoperative and team dynamics? In all these surgeries, strict BP management, maintaining cerebral perfusion pressure and mean arterial pressure is of prime importance, and judicious fluid administration is important. And neuro monitoring, as I mentioned earlier, and monitoring of blood loss, anticipate and keep the blood products ready. And in emergencies, rapid response protocols for massive hemorrhage, massive transfusion protocols, and similar way for venous air embolism and ICP crisis. So what are the things we need? A proper team and effective communication. Preoperative area, definitive surgical plan, patient risk and role allocation has to be done, and closed loop communication essential for complex cases, often requires multi-specialty involvement, ENT, oromaxillary facial surgery, orthopedics and plastic surgery. Cooperation is needed in case of most of the polytrauma patients, and training and simulation, regular drills for critical events, especially in mass casualties, which has been already explained that we had encountered 2 mass casualties in last month. And post-operative and continuous improvement. Post-operative care, we need to have extubation strategy of the neurosurgery patients, balanced neurological assessment and airway protection, and multimodal analgesia, and comprehensive handover from ER to OR and OR to ICU, and continuous learning and quality improvement through mortality and morbidity meets, audits, and staying updated. Conclusion: excellence in neuro and spine anesthesia hinges on rigorous preparation, vigilant intraoperative care, and cohesive teamwork. What we do in Amara Hospital: we have state-of-art modular operating rooms, team of 12 specialized anesthesiologists ensuring 24/7 coverage of operating rooms and ICUs, and availability of multi-specialty surgeons, advanced neuro monitoring equipment, airway management equipment, and fully equipped modern neuro ICU. And we conduct regular CMEs to keep ourselves updated, and monthly mortality and morbidity meets to ensure patient safety. This is our anesthesia and critical care team who provide services 24/7, and this is the entire neurocritical team who are involved in providing quality care for the patients. Thank you.
Thank you, sir. Thank you for the valuable insights. Now I request Dr. Ramesh Chandra, sir, to please present the memento to Dr. Rakesh, sir, as a token of gratitude. Please give a big round of applause.
Thank you, sir. I would now request Dr. Yashwant Sandeep, sir, consultant neurosurgeon, to present his talk and give us insight about the challenges in neurosurgery. We welcome you, sir.
Good afternoon, everyone. Myself, Dr. Yashwant, consultant neurosurgeon. We are a part of neuro team headed by Dr. Anand sir, and I welcome all the guests for attending this neuro conclave today. I welcome our chairman sir, Prasad sir, and Rama ma'am, and thank you, chairman sir, for giving this opportunity and keeping faith on us, allotting a lot of gadgets and high-end equipment for us to operate at this part of area. And today I am going to so I am going to discuss two cases today, very interesting cases. First case is a history we have taken from the patient. It's a patient C. We can't name the patient. So he came with neck pain and severe headache for the past 1 year. His pain radiating to both hands, tingling paresthesia, unable to walk, sleeping while walking. Why I took this case interestingly is this case, he suffered all these symptoms when he was working in the abroad. He came directly from abroad, landed in the airport in Chennai. He directly came to the Amara Hospital in the wheelchair to our OPD. So he has given all these symptoms which he had for the past 1 year. So suddenly he deteriorated with all the symptoms at his workplace in the Kuwait. He is actually laborer working in the Kuwait. He hails from Kadapa. Actually, whatever I told earlier, from airport directly to the Amara he came. So we have examined the patient. He is a significant weakness in all 4 limbs, DTR exaggerated, Hoffman's positive. The grip was significantly decreased. He was unable to button his shirt, unable to mix food, so many other things he was having. So this is the basically cervical presentation. Wherever the patient was having significant compression in the spinal cord. Yeah, this is the pre-op MRI. As soon as he landed into our OPD, as soon as we examined, we have ordered for an MRI, where you can see there was severe critical cervical stenosis noted at the C3 to C5 with calcified ligamentum, everything, PLL. See, the cervical cord has literally become paper thin. There was no. When we have measured the spinal canal diameter, it is almost 3 mm. So, this is the axial cut. So, our immediate diagnosis was C3 to C7, severe cervical spondylotic compressive radiculomyelopathy. So, we have planned a surgery after all the pre-op workup, and we have state-of-art cardiac team where they give clearance to the high-end cases also, sick cases also with challenging thing. And this is the intra-op picture where we have done a wide door posterior laminectomy, where we have decompressed the cervical cord with supporting the cervical vertebra with lateral mass screws. This is the X-ray, post-op X-ray of this particular patient, where we have done 5 levels C3 to C7. You can see all the implants were in position supporting the spinal column. So I just want to simple about cervical spine. It is a very smaller, cervical spine vertebrae is the very smaller ones. They are very narrow and overlap. They are called as lateral masses. Superiorly, inferiorly, facet extend from the pars. So this is one more picture of anatomy of the cervical spine. So degenerative diseases, why I want to highlight this thing is most part of the common people, laborers, workers, nowadays software engineers, everybody is having these type of complaints. Due to wrong posture in the neck, their excessive two-wheeler driving, excessive wrong posture during the sleeps, there was early degeneration, lack of exposure to sunlight, lot of dietary things, changes. So many, all these things, lifestyle pattern, as I told, diet, everything, taking junk food, obesity, all the things. So it all leads to the severe compression in the cervical spine. So this degenerative disc disease, actually previously we used to have these disc diseases above 40, 50. Nowadays in 20, 25 age people also, we are having so many disc diseases. So mainly in the cervical, what happens is this disc which is which has a lot of water content. Slowly this water content will be gone out, and whatever the soft content of the disc, it comes out after there is a rupture in the annulus. So changes in this disc structure and function is lead to the articular facet further, resulting in the redirection of the compressive loads. Whenever there is this load-bearing disc, which is like shock absorber, when it is torn out, there will be a lot of compression over the cervical canal, mainly spinal cord. So this is one more MRI which we have. You can see there is a mild nucleus pulposus compression. So all these minor compressions, without any significant symptoms, no need for any immediate intervention. So cervical collars with some NSAIDs and physiotherapy and massages and some posture correction, those things will be enough for the minor things. So these are the first, the MRI, CT and patient examination are the main diagnosis criteria. Initially we go with the medical management for the, but in this patient, as you can see, there was significant compression. We can't wait for, he was an impending severe weakness, and immediately he needs surgery. So we have planned surgery in this patient. So non-operative treatment includes cervical support, hard collars, soft collars, analgesics, root blocks. Root blocks are nowadays getting very much advanced, and ultrasound guided root blocks we can try for a little bit period of time if patient gets proper relief. So the goal of treatment is that prevention of avoiding the prevention of permanent spinal cord or nerve root injuries. In mild cases, if treatment is not required, usually stabilize with simply neck braces and NSAIDs, as we told. So these are the indications for surgery. As in our case, indication is very much there, because he is having severe weakness. So we have went for a surgery. So what surgery we are going to plan for this patient? More than 2 levels and severe, taking into his age. So we need to go for a posterior approach. What here I am showing is the anterior approach, where we will be doing single level anterior cervical discectomies, corpectomies, and nowadays most advanced endoscopic cervical, both anterior and posterior approaches are coming. So posterior approach, what we have done here is cervical laminectomy with lateral mass screw fixation, where in the earliest MRI, X-ray, I have shown all the 10 screws were in position and supporting the patient. So these are some of the posterior cervical things. This is the anterior cervical discectomy, where it is a single level. Nowadays we are able to do with a microscope with very small incisions, so very minimal stay. We do a lot of these type of cases in our hospital, where patient will have only isolated single level involvement, where single nerve roots are pinched and respective dermatomes are involved and pain is severe. So we have picturized a few steps there. So this is corpectomy, where plating is necessary, fusion. And so this is the posterior cervical lateral mass with laminectomy. So this is this particular patient which we have operated. This is our post-op MRI, where you can see significant relaxation and widening of the laminectomy, showing in the from C3 to C7. See, you can see the CSF space restored. The spinal cord is floating literally, and the patient is immediately improved within 3 to 4 days after surgery, after proper physiotherapy and for few weeks of collar support. He was able to do his not like too much aggressive heavy work, but he can have a good life. And this is the patient picture. Okay, it's not coming. We feel very much happy when we see our patients' videos, pictures after surgery. They're getting improved a lot. And this particular patient, we very much remembered. Sorry, he came in a wheelchair to our OPD straight from airport, and trusting a lot on us and Amara. Thank you, Chairman sir, providing all the necessary equipment for us to operate. Thank you. Now we are going for the second case discussion. Yeah, this is our second index case. This is a patient. This is also very much interesting case. Why we have selected is this particular patient is also not from Tirupati. He is from Bangalore. The thing is, he roamed around in Bangalore for so many days, visiting so many local clinics, even going for a big corporates there. So finally, he came to know that high-end work and good work is going on in Amara, and he trusted us, came here, and it was very happy for us to operate on this patient under the guidance of Dr. Anand sir, and everything went well, and patient is now sound, hale and healthy. So this patient, his history is 7 years back he had some accident. He is like coconut vendor. He stays by the road and he used to sell coconuts, and he had some trauma, some injury, he don't know properly. After that he was fine, but not much deficits or anything, only for a consistent neck pain he was having. That particular neck pain was radiating to the left hand. So over a period of time, he was having difficulty in walking. Slowly, he was having difficulty in holding the objects. So similar examination, classical cervical examination, all four limbs we have examined. Tone mildly increased, exaggerated reflexes, Hoffman's positive, grip same. He was unable to mix the food, and his wife was always mixing and feeding him. So rest all fine. So this is the normal anatomy of CV junction, where you can see tip of dents in adjacent to that in front, C1 anterior arch, posteriorly C1 posterior arch, and spinal canal. So this is the X-ray of this particular patient, where we have done X-ray flexion extension, where you can see there is a small arrow mark. Atlantodental interval line was more than 5 mm. So immediately we have done an MRI. So you can see there was a severe compression noted at the level of C2. There was an old fractured non-healed odontoid, and further giving that led to this particular symptom to the patient, which is severe compression noted at C1, C2, where the cord is also very much thinned out due to compression. This is the CT CVJ. You can see there is a fractured odontoid, non-healed. So we came to an diagnosis called mobile atlantoaxial dislocation at the level of C1, C2. So this is some anatomy about the C1, C2. C1, C2 is a craniovertebral junction, is a collective term, the occiput, atlas, axis, and supportive ligaments. It's a transitional zone, something it is like Lagal junction between the head and spine. It's a mobile cranium. Cranium you can move left, right, front and back, a rigidly stable spinal column. So it also has the soft tissue structures of, it encloses the soft tissue structures of the CV junction, mainly the lower part of the brain medulla, spinal cord, and lower cranial nerves. This is the one more anatomy of the CVJ. You can see occiput, C1, C2, C1 atlas, and C2 axis. This is the major anatomy of the CVJ. Principally stabilizing ligaments, transverse atlateral ligament, alar ligaments. Secondary stabilizing ligaments are more elastic, weaker than the primary ligaments. Primary is the main which supports. Secondary ligaments are apical, anterior, posterior, tectorial membrane, ALL, PLL. So atlantoaxial ligaments like anterior and posterior atlantoaxial ligaments. Transverse ligaments of the atlas, they are very thick, strong, and they help in allowing a free gliding motion to occur over a facet of the dents. So, in whole of CV junction, transverse Atlanta ligament is the main thing. Its function is to prevent the displacement of C1 over C2. Why I am highlighting this thing is nowadays there are a lot of road traffic accidents where people are not wearing the seat belts. Whenever sudden accidents happen, there is this hyperextension of the skull at this CV junction happens, and immediately patient is having a high cervical injuries, C1 fractures, C2, everything. And nowadays kids during their playing at the gardens, any sliding, paragliding, jumping every day, swimming pools also they are getting injured due to this C1, C2 injuries. So we tell that parents to be careful. So these are all the basic anatomy, which I don't want to go depth. So hyperextension, as I have explained, fracture of the posterior arch of C1. This type of injury occur when occipital spinous process of C2 collides with posterior arch of C1 during hyperextension. Failure of the posterior arch disrupts the continuity of C1, which may cause immediately, but ligamentous damage. So odontoid fractures. This is the X-ray where you can see the incompetence of the odontoid fracture. This is called Greenberg classification. Traumatic fractures of the odontoid, sometimes infections, sometimes incompetence of the ligaments, sometimes it is congenital. This is the classification of atlantoaxial dislocation, which I don't want to go depth into it. So whenever the injury, what is the treatment? Type 1 injuries, stable subluxations, we will go with a hard collar. Type 2 injuries, potentially unstable. Type 3 and 4, rotatory displacement are unstable and should be treated surgically with reduction of C1 to C2 fixation, which we have done in this patient. He is telling that I will certainly refer the patient from my surrounding areas to Amara. And this, you can see, now his weakness very much improved. He is able to move his hands, and he is totally happy that he is able to eat his food, mixing his in his own plate and all. We are very happy to see such patients coming with good outcomes. So that's what's. Thank you so much for giving me this opportunity. Thank you.
Thank you for your valuable talk, sir. I would now request Dr. Sudhakar Reddy, sir, Senior Neurosurgeon, to present the memento to Dr. Yashwant, sir.
Now I request Dr. Anand sir to please give a memento to Dr. Ramesh Chandra sir. Thank you, sir. Now I'd like to request Dr. Anand VK, sir, Head of the Department and Senior Consultant, Department of Neurosurgery, to please address the stage for the most awaited scientific talk.
Thank you, Dr. Venkatesh. First of all, I take this opportunity to congratulate our neuro team to celebrate the 2025 World Brain Day. And it's my immense pleasure and honor to address respected Chairman Sir, in front of respected Chairman Sir and Madam and distinguished guests. And I take this opportunity to present some of the great cases we have done from last 1.5 years. We have operated almost around 330 plus cases, around 15 plus skull-based cases, and CV junction around 5, 3 aneurysms, 1 AVM, and spinal trauma around 30 plus cases. Totally around 330 plus cases we have operated, out of which around 160 cases from the emergency trauma. Thanks to Dr. Shivaram Krishna and team for providing so many trauma cases for us. So without moving to the slides, I just jump onto the index cases. So this is the first case which I am going to present. It's a middle cerebral artery aneurysm. And what is an aneurysm? Theoretically, aneurysm is a balloon-like dilatation, and the word is derived from the Greek. The first was quoted by Galen, and ana means across in the Greek, and juxtaposition, broad dilatation, that is uris. That is called the aneurysm. The both words comprise the aneurysm. The first surgical clipping was done in 1937, almost 110 years before to this day, by Sir Walter Dandy. And there are different types of aneurysms based on the etiology, morphology, and size. According to size, less than 4 mm aneurysms are called baby aneurysms, and 5 to 10 mm aneurysms are called small aneurysms, and around 10 to 25 aneurysms who have a size of 10 to 25 millimeters, they are called large aneurysms. More than 25 mm aneurysms are called giant aneurysms. We have operated almost all cases during my entire career of spanning around 14 years. And what causes the aneurysms? The intracranial arteries differ from the peripheral arteries in terms of histology and the blood supply. Histologically, intracranial arteries, they differ from the peripheral arteries in terms of the thickness of the tunica media. The tunica media is lesser than the tunica media of the peripheral arteries, and they lack the external elastic lamina. The external elastic lamina is completely absent beyond the petrous segment of the ICA, and they do not have vaso-vasorum. So the after petrous segment of when the ICA crosses to the petrous to the lateral segment, the vaso-vasorum stop. So the blood supply to the interior of the intracranial vessels comes from the direct blood flow. So that is the reason why these aneurysms are more common intracerebrally, and 20% of the aneurysms are multiple. Some of the aneurysms are associated with polycystic kidney disease, adult polycystic kidney disease, Marfan syndromes, fibromuscular dysplasia, triple Tranavate syndrome, and so many genetic syndromes are there. And some people are genetically predisposed to the formation of aneurysms due to the chromosomal abnormalities at chromosome number 1p and 34q. These are some of the causes. And apart from the presentation, classical presentation as subarachnoid hemorrhage, around 20 to 40% of the patient may present with intracerebral hemorrhage, ICH, most commonly by ACOM and MCA. And some of them, they have intraventricular hemorrhage. Some of them have presented with SDH, and the cavernous ICA aneurysms typically present with cranial neuropathies, either sixth nerve palsy or third nerve palsy or trochlear palsy. This is my first index case. She is a 54-year female, came to with a casualty with a history of sudden onset severe headache with neck pain, followed by loss of consciousness for about 5 minutes with a history of 1 episode of seizures associated with falling of the mouth. And she regained the consciousness. She landed in the casualty. At casualty, her GCS was E3 before M6, but drowsy, arousable. And severe necrosity was, there was no deficits. Baseline, all investigations were normal. CT was showing this.
Screen pointer pointer.
You can see the plain CT. There is an extensive subarachnoid hemorrhage at the base of the skull involving the involving the crural system, interpedicular system, suprasellar system, bilateral sylvian fissures, interhemispheric fissures, and along with that she had an interventricular bleed. So that amounted her to belong to a modified fissures grade 4. And clinically she had scaling of grade 2 according to Hunt and Hess, and she had a risk of vasospasm around 33%. So CT angiography showed the MC aneurysm, small MC aneurysm, distal segment of the MCA, probably where the M1 is written, that is the point where the aneurysm was arising. So MCA is divided into 4 segments. The horizontal segment, that is the cysternal, M2 is insular, M3 is opercular, frontal opercular branches, M4 is cortical and distal branches. So most often M1 or M1 bifurcation aneurysms are most common. This is the position where the head is turned to the opposite side with the malar prominence at the highest level of horizontal plane, fixed with the 3-fin Mayfield head holder, and this is how we dissect the scalp, preserving the frontal branch of the facial nerve. This is standard pterional craniotomy, but we did not do pterional craniotomy here because the brain was angry and there was edema. So in order to decompress the brain, we did a large trauma flap. Okay. So dura was opened in curvilinear fashion, base towards the skull base and sphenoid ridge. Sphenoid ridge was drilled till the middle fossa and flush with the middle fossa floor. And this is how we open the sylvian fissure. This is a video, operative video. We started dissecting from the skull base. This is the medial aspect of the sylvian fissure, where we have that is the optic nerve. This is the optic nerve, and this is the subarachnoid space over the optic nerve. I am operating over at the opticocarotid cistern, cutting all the arachnoid, draining the subarachnoid hemorrhage. You can see a lot of blood stained CSF coming out. This is running fast because we have to accommodate the time. This is almost a 3-hour video, so I made it a little shortcut with the 7 minutes. So running fast. This is the internal carotid artery. That is a PCOM here, posterior communicating artery. And I applied the retractor to define the ICA bifurcation into ACA and MCA. And again, this is the optic nerve coming from medial to lateral side. That is arachnoid which I am cutting. That is the membrane, as Dr. Madam Radhika said, that is the membrane which covers the blood vessels with the underlying CSF. We have to preserve the lenticular straight arteries which are coming from the M1 segment. Sound point. Again, I am coming from lateral to medial side, so that both sides I should join the sylvian fissure. So the entire sylvian fissure is wide open like a book page. Video better. That is arachnoid. This is the distal MCA you can see here. There are some veins, superficial middle cerebral vein. That is a surgical hemostatic agent to cover the rough surface. Sometimes we may rub the tip of the suction with the cortex. So in order to avoid the injury to the cortex, we keep some surgical around. I think sir also does the same practice. So now I expose the aneurysm, cutting arachnoid fibers over the aneurysm neck. You can see a single aneurysm with a small blister-like aneurysm in the lateral, posterolateral aspect here. This is adhesions between the neck of the aneurysm and the frontal lobe. This is the MCA distal to the aneurysm. Now you can see the complete exposure of the aneurysm along with the neck, and this is the sort of a blister type of an aneurysm. It's a daughter sac. This is the daughter sac. Probably this was the site of the bleed. By the time we operated, everything was sealed off. Left side was completely normal. ICA, other branches of the anterior circulations were normal. Even ACOM was normal. So this is how I did not use the temporary clip, but it looks like a straightforward case for me. So directly I applied a permanent clip. So one clip and another clip at the base of the blister to complete the clipping. After this, everybody in the operation theatre started that we have completed surgery, congratulations, congratulations. It was not complete unless we do some other procedures. So I tried to open the lamina terminalis, which is the entry aspect of the third ventricle, a thin membrane connecting two optic chiasmas, two posterior aspect of the optic chiasmas. This is the base of the skull. This is the optic nerve entering into the optic foramen. This is the anterior clinoid process somewhere here. This is the anterior cerebral artery A1. You can see artery of Hübner here that supplies the internal capsule, anterior limb of the internal capsule. This is the Hübner's artery. This is the lamina terminalis. This is one optic nerve, the other optic nerve here, this is the chiasma, and this is the lamina terminalis. So we just touch with the bipolar, keeping around 5, make a rent, small rent with a dissector, so that the CSF circulation is established into the subarachnoid space. And CSF can be drained over the convexities. Because the patient, remember, the patient had an intraventricular bleed including the third ventricle. So there was high chances of developing obstructive hydrocephalus in the post-op period. So another advantage of draining blood clots is that the incidence of vasospasm significantly reduces once you remove the significant clot amount in the subarachnoid space, because the vasospasm is directly related to thickness of the subarachnoid hemorrhage in the cisterns. So that was the end of the video. So that was the surgical aspect. Patient underwent surgery very well, she tolerated. There was no issue. When we shifted back to the ICU, within 10 minutes I got a call. I already was going back to home after finishing tight surgeries, and so before reaching home, I got a call from the ICU doctor, one of my intensivists, stating that the patient has arrested. And she gradually developed bradycardia and hypotension and desaturation. She arrested. Immediately CPR was done and ROSC was achieved within 5 minutes. And later on we evaluated what went wrong. So we got CT done for the brain. Brain was showing absolutely fine. There was no infarct, no bleed, nothing. Clip was in place, no rebleed, no other remote site bleeds. Posterior fossa, everything was normal. But our 2D echo labs, CT chest showed tocorsumovo cardiomyopathy. It's a sort of a stress-induced cardiomyopathy. And later on, 2D echo showed ejection fraction of around 35%. Normally pre-op, she was 60% having ejection fraction. So she was managed with the complete knock-off with sedation, muscle relaxant and propofol and beta blockers and the infusion of diuretics. And almost after 2 to 3 days, she regained consciousness. And after 4 days, she became conscious. And 5th day, she was completely conscious, moving all 4 limbs with E4, V5, and 6, VTM6. She was still intubated. Later on, she started developing patches in the lung. Then we did prophylactic tracheostomy and rehabilitated her, sent to rehabilitation. This was the post-op scan. This was the CT angio showing very. It's not working. This is the clip. This is the clip. Post-op CT angio, no residual aneurysm, no blisters. This is a post-cranioplasty. And at present, so much confusion. So, wait. After 1 month of post-op period, she came to OPD with this. And later she found out to having early Parkinson's disease also, and she was later taken over by Dr. Vijayendra for anti-Parkinson medicines. And this was the recent most video. Remember, this is the post-arrest patient. She did not have a heartbeat for 5 minutes. Luckily, Dr. Vishal was here and he immediately recognized, they called medical ICU people also. So ultimately, it was a teamwork. So thanks to all my intensivists and supporting staff. Coming to the second case. Wapas file. Next case. So why so many? You take one, give me one. This is 65-year female. She came with progressive weakness of all 4 limbs, later on slurring of speech and urinary incontinence. And she came with foliage. And if you see the MRI, this was done on 21st of February. Within a week of my joining in Amara Hospital, she came with some scans from others hospital. And this was a scan which was showing a big meningioma at the foramen magnum level. It's too much. Somebody set it right, please. So she came first to me on February, and date of surgery was 13/6, February to June. She disappeared. She was not coming to follow-up. She didn't go to any hospitals, making arrangements for our surgery. And she landed with the severe spasticity, high cervical myelopathic signs, and she had power of 3/5. And this patient also had a robust post-op course. Almost she stayed in 1 month in the ICU with tracheostomy, with multiple episodes of infections. And this was the MRI, this T2-weighted MRI showing a large meningioma arising from the entry lip of the foramen magnum going upwards like this, compressing the cervicomedullary junction. It's not visible at all. You can see the cervicomedullary junction was constricted like a paper. It's no space for breathing. This was a contrast MRI. You can see the dural tail with a huge mass compressing the medulla completely and the upper cervical cord up to the level of the upper border of the C2. And the axial scan, coronal scan, complete occupying the subarachnoid space. And identify the structure. This is the vertebral artery which was passing through the tumor. And the tumor was involving the vertebral artery and the lower cranial nerves. So, if you see this was the region. This was the region where the tumor was located, and the entire cord, medulla, lower part of the pons, medulla, and the cervical cord was shifted to one side, like this. Our patient belonged to the group D. This was the area where we operated, and according to Michael Lawton group from the Phoenix, Arizona, our tumor was belonging to class F, type 4, class F, with a bundle crossed and encased, and vertebral artery was also encased. This was type 4 tumor. These are different type of approaches where we go to the CV junction, to the anterior aspect of the medulla and foramen magnum level and upper C1. And we choose to do a suboccipital cranectomy and hemilaminectomy of C1 with slight tilting of the table towards one side. And we operated under intraoperative neuromonitoring. This is the operative video. This is the anterior aspect towards the face. This is the C1 here. This is the foramen magnum. This is the posterior aspect. This is the cranial, caudal. This is the tumor. Whatever red you see here is completely tumor. This is the spinal accessory nerve crossing over the tumor from the spinal roots going up and joining the cranial aspect. And this is the pica. This is posterior inferior cerebral artery. So identify the lower pole. We always come from the lower pole whenever we have these type of tumors, so that we should not injure the brainstem at the earlier stage. One should be very careful. One should have a depth assessment, hand-eye coordination, and the tensile strength of the tissue. One has to be very careful while holding the tissue. Tissue handling, very important. And the tumor was very hard, and it was like a stone sitting in the subarachnoid space. So we started decompressing the tumor from the lower pole. This is a cavitronic surgical aspirator, ultrasonic aspirator, which uses ultrasonic high frequency ultrasound waves to fragment the tumor, and at the same time it has another port which sucks the tumor. So this is how I decompress the tumor from the lower pole. Sound indicates. This is the anterior aspect of the tumor. This is the posterior. This is the medulla. Whatever you see here, this is the medulla. And this is the high cervical cord. This is the cervicomedullary junction. You see the slight bulge here, could be the pyramids from the lateral aspect. These are all the perforators. You should not coagulate or fiddle with any of these vessels, otherwise the patient will not wake up for the entire life. And this is the vertebral artery, which I was showing in the MRI. This was the vertebral artery which was encased from above. This is also tumor. This is also tumor. This is coagulated and cauterized. That's why it was looking yellowish and pale. This is a flesh tumor, the tumor mass. So further decompression. Now I am lifting the tumor from the medulla, anterior aspect of the medulla and high cervical cord. I could not. Then I again went ahead. Now I am decompressing coagulating and decompressing the tumor above the vertebral artery. This is the vertebral artery. Now we can see I completely skeletonized the vertebral artery on 360 degree. It was encased. Further decompression. This is the posterior inferior cerebral artery which is arising from the vertebral artery. This is the basilar artery. This is the medulla here. This is the clivus, cervicomedullary junction. This is the entry of the vertebral artery through the posterior atlanto-occipital membrane. A small part of the tumor was going inside the lower cranial foramina. So when I was doing this, patient started developing bradycardia, probably due to the stretching of the brainstem. So I kept a little bit of tumor at this stage. So I thought that is the day. So it was almost 7.5 hours from the beginning. So that is the basilar artery. Yeah, this is the anterior to the basilar. That is the retroclival space. This is the retroclival space. So this is the entire tumor cavity. You can see the complete post-op. And this is the dura which was burned along with the dural tail. And this is at the end of the surgery. You can see the pulsatile medulla with spinal cord and the vertebral artery. I closed the dura watertight so that patient should not suffer CSF leak post-operatively. This is the post-op scan. You can see the restoration of the anterior subarachnoid space here in the pre-pontine cistern and premedullary cisterns. You can see all the subarachnoid spaces open. Posteriorly, the free flow of CSF. This is the scan, post-op contrast MRI, follow-up after 6 months. Dural enhancement, no gross residual. That's the dural tail. So histopathology came out to be a grade 1 tumor. So this is the latest video I got from WhatsApp. She was in touch with me. So this is what is the latest modified Rankin scale, independent 0, MRS 0. She stayed with us for almost 1 month due to failure to start her own respiratory breathing efforts because of the long-term compression at the medullary and cervicomedullary respiratory centers. So she underwent tracheostomy, had bouts of infections, later recovered. Now she is speaking normal. So next. This is the recent most picture. She was in the back in the ICU to identify her beds. She was in bed number 3 in the neuro ICU. She met all of our heroes who have done tireless work. Thanks to all the heroes. All these are our heroes. We operate and go home, but most of the things are taken care of by our angels. So it's a thankless job, but we have to greet them always. We have to push them up. Next stage. ఇక్కడే ఉండు బాబు, టైం పడుతుంది. The third case, my third case is acoustic neuroma. She came with deafness, next, deafness and tinnitus. Headache and pain and deafness and tinnitus from last 4 months. She was non-diabetic, and on examination she had a 50% sensor loss for the left half of the face and severe sensory hearing loss on the pure audiometry. Speech discrimination was more than 50% loss, and fundus was normal, vocal cords were normal, rest of the functions were normal. And this was the tumor again at the CP angle. So this was belonging to grade 3 according to Coos, because of the size, and it was reaching up to the brainstem. We consider it as a medium-sized tumor, and we routinely use suboccipital approach, retromastoid suboccipital approach for taking out the tumor. And we are familiar with this approach, and it is the best exposure what we can get at the lateral aspect of the CP angle, and the CSF lake is lesser than the midline suboccipital. This is the position, this is the incision where we give exactly 2/3 between the iniomastid line, 2/3 medial and 1/3 lateral. The junction is the asterion where we make the center of the incision. 1/3 is up and 2/3 is below with a lazy incision like this. And this was the video. So this is the CP angle, cerebellopontine angle. This is the cerebellum. You have pons behind this tumor. I will show you. This is the mastoid base. This is the caudal. This is the cerebellum lateral surface. It's a cranial head end. And this is the transverse sigmoid junction, transverse sinus and sigmoid sinus junction. This V is the transverse and sigmoid junction. The tumor is decompressed internally and separated from the cerebellum. So one should not breach the arachnoid lying between the tumor and the cerebellum. Once you breach the arachnoid, you will lose the plane. So one has to be within the plane so that we should not injure the normal structures. So one started removing the tumor from the lower pole. Always prefer to remove the tumor from the lower pole so that the lower cranial nerve should be protected. These are the lower cranial nerves, glossopharyngeal, vagus nerves. This is lower pole. Now you cut the arachnoid. Once you dissect the arachnoid, you will see the pons here. And continue decompression. So keep on continuing decompression till the capsule becomes thin enough to pull it out from the normal structures. Now this is the arachnoid. What you can see now is the pons, the anterior posterolateral surface of the pons. So we continue to decompress the tumor, resected. At the same time, find out for the facial nerve. Facial nerve usually lies anterior superior to the tumor. So till then, keep on dissecting, go from lateral to medial, sometimes medial to lateral. I am using intraoperative neuromonitoring electrode to the sort of electromyography, neuronography, so that the facial nerve is intact. So we have to monitor facial nerve throughout the surgery, because sometimes the patient nerve comes from posteriorly, inferiorly, or sometimes anterior to the posterior to the tumor. So entirely a bare facial nerve can lie posterior to the tumor. So we need to know where exactly. The idea is to protect the facial nerve, so that post-op should not suffer facial nerve palsy with the exposure keratitis and drooping. Somewhere here I identify the facial nerve. You can see the facial nerve is thin, stretched out. This is the facial nerve. So one has to separate, gently lift the tumor off the facial nerve. Sometimes it bleeds. So don't coagulate it. So just put a surgical gel foam, wait for some time, irrigate it, it will stop. So further tumor removal. This is the facial nerve now. You can see the facial nerve, and this is a complete tumor which is arising at the internal auditory canal. So after completion, one can see the facial nerve here. This facial nerve, it's the tentorium, and this is the fourth nerve. This is the tentorium, this is the fourth nerve, this is the arachnoid. This is the dorsal aspect of the midbrain. This is a post-op scan, recent scan. You can see a small residual here in the internal auditory canal. So we don't need to do anything for that because it's a benign tumor. She has lucky enough to have an intact facial nerve post-operatively. Next. Biopsy was suggestive of acoustic with grade 1. So this is a post-op. You can see in the House-Berkman scale, grade 2 facial nerve palsy. She is a complete closure of the eyelid. That was the target of the rehabilitation of the facial nerve. So she is completely avoiding exposure keratitis, so many issues. Thank you. Next case. This is a common entity, every neurologist having a few patients per month. It's a trigeminal neuralgia. In females it's more common. And typical lancinating, stabbing-like, cutting-like, knife-like pain over the distribution of the trigeminal nerve, most commonly in V2, V3 combinations. Most often these patients go to dental doctors initially for caries, thinking that the caries is happening, dental caries. So some people come with some of the missing tooth also. So earlier in the beginning, most of the neurologists treat this case, and the disease progresses. The period of exacerbation takes over the period of remission, even with the maximal medical therapy of 1,200 to 2,000, 1,400, 1,600 carbamazepine. And some people use baclofen, thinking that it adds to the effect of the carbamazepine by decreasing the excitatory synaptic transmission in the trigeminal nucleus. So most of the treatments like Most of the patients get this best relief by the surgical treatment, and other treatments are ablative treatments and peripheral procedures. These other ablative procedures and peripheral procedures are reserved for the patients who are not medically fit for surgery and who have a failed trigeminal neuralgia surgery or multiple surgeries even after MEDs. So these patients are very small number. Most of the time the MED, microvascular decompression, leads to more than 95% success rate. So most commonly the superior cerebellar artery is involved in compressing the trigeminal nerve at the trigeminal cistern. So this is a small video where I decompress the trigeminal nerve. So again the same principle like CP angle, centering at the asterion, make multiple burr holes so that you can do appropriate suboccipitary craniotomy. Open the dura to the medial side, make a T-shaped cut, multiple dural leaves, open this cerebellopontine cistern. One should not apply retractors here. So first we have to release the CSF from the cisterna magna so that the cerebellum falls down, no pressure. Then you go inside to release the trigeminal nerve from the adhesions. The arachnoidal adhesions, they are dissected. That is the superior cerebellar artery loop, that is the tentorium cerebellar, and that is the petrous bone. This is where the nerve is entering into the Meckel's cave. This is the Dandy's vein. This is the fifth nerve. So I am cutting arachnoid so that the superior cerebral artery is completely freed from the trigeminal nerve. All adhesions have been cut. So now you can see the gap between the superior cerebral artery and the trigeminal nerve. We take bits of Teflon which are non-immunogenic, neutral. The same Teflon which is used to close the ASD or VSD in the cardiothoracic surgery. So put a lot of Teflons, pack the cistern, so separate the trigeminal nerve. Do not pull or push any vein here, because post-operatively patients will have persistent vertigo and vomitings because of the affection of the vestibular nucleus and edema. So I am using a wrong instrument. I corrected myself to pick up the proper instrument. This was the wrong instrument. I was pushing the Teflon with a flat dissector. Now you can see I separated the vein from the trigeminal nerve throughout the length. Then I freed the root entry zone of the fifth nerve. The vein is separated. The vein is separated from the root entry zone. I took some time to separate it. That ends the surgery. This is the internal aortic canal, where the 7th and 8th goes. This is the Meckel's cave entering, the trigeminal nerve entering into the Meckel's cave. This is petrous, tentorium, lower cranial nerves, the Ica loop. Thank you. And this is the post-op. Same patient with consent. We have taken a video. This patient was very happy. He has a son and daughter in US. They asked multiple doctors to where to go. Ultimately, they landed to us, and he had given good review. This video I took it from the our own website. So that's it from Neurosciences side. Thank you, sir. Thank you, madam. Thank you all friends for giving me an opportunity. And I ask Professor Ramesh sir to comment on my surgeries. Thank you. Sir is my senior from PGI days way back in 2005 to 2007. So later on I jumped to Delhi. Sir remained in PGI and then he came and joined to SPMS. He is a very extinguished, one of the few surgeons who can do a lot of difficult surgeries. What we are doing more than probably in numbers and in difficult cases in terms of the surgical qualities. So over to you, sir. Please comment. Thank you.
Thank you, Anand. I think I know Anand since 2002 or 3. So very hardworking and enthusiastic resident. I think after seeing his videos, I think he hasn't changed much. He has been the same. So very good work. I really feel proud that you are doing really complex cases with good outcomes, and you have a very good team support. So, and I wish you all the best. So to have a very good future in all your future endeavors. All the best. Thank you.
Thank you, sir. That was really an interesting session. Now I'd like to request Dr. R.R. Reddy, sir, to present a memento to Dr. Anand, sir. Please give a big round of applause. Thank you, sir. Now I request Dr. Anand, sir, to present a memento to Dr. Sudhakar Reddy, sir.
Thank you, sir. As we all know, the advances in imaging has made neurodiagnosis and treatment follow-up more precise and accurate. Imaging has become part and parcel of neurosciences. Now we have our senior consultant radiologist, Dr. Vinod Saravanan Garu, to give us introduction on MR imaging along with histopathological correlation of intracranial tumors. We welcome you, sir.
Good evening, everyone. And just an introduction to imaging and histopath MR correlation of intracranial tumors. You all know MRI is a magnetic field, and the magnetic strength of Earth is 0.5 gauge. And we have a 3T mission, which is almost 60,000 times the magnetic power of Earth. And what is the role in neurosurgery? So, as a radiologist, we should know the clinical knowledge, neuroanatomy, pathophysiology, and collective of all the data, and to give a differential diagnosis and clear-cut diagnosis, and to the level of close to histopathological diagnosis. With advent of higher Teslas like 3 Tesla and 7 Tesla in research, we were able to come very close to the histopath diagnosis. And so basic sequences like we do routine T2, T1, flare, SWI, drive, and MRA, MRV, and post-contrast images, angios and perfusion images, and MRS and DTI. All this are available in our 3 Tesla images. And just to show little bit about basic sequences like T1 images, which appears gray, gray matter appears gray and white matter appears white, and it is opposite on T2. And flare, the fluid signals are suppressed like CSF fluids. And just to show the basic resonance of substances like Na and other things at MR spectroscopy. And MR spectroscopy helps us in making a better understanding of metabolites within the tumor component or a tissue component. And it helps us to differentiate between a neoplasm and non-neoplastic diseases, from grading of tumors into recurrent and recurrent versus post-radiation necrosis. This is to show image how the multivoxel spectro appears on the MRI. So we can take anywhere from comparison for a normal to the abnormal images. You can see that this is a normal to abnormal. We can take anywhere, and we have both single voxel as well as multivoxel. So single voxel, we use it for better diagnosis because it is more accurate, whereas multivoxel, we take the total MRI brain also for a comparison, and we have a short, long, and intermediate TE for a differentiation. People say MR spectro is a lengthy procedure. It is almost takes 40 minutes, and generally commercially people do for just one sequence and try to make a diagnosis. But here we do a dedicated work. And just to show, A is a single voxel images of low TE, that is 30, and this is intermediate TE. So just to differentiate low TE, you can appreciate lactate and lipids and myoinositol. And intermediate, we can see the reversal of lipid lactate peaks, just for basic understanding. And N-acetyl-aspartate, it's a very common metabolite at resonate at 2.02, and it is a common, it is a neurological marker, and it is elevated in very few conditions like Canavan's. You can see this Canavan's white matter disease. So it is the only condition other than SELAS and others where Na is increased. Easy to make a diagnosis. Most of the time we make a straightforward diagnosis based on MRS. And creatinine is a normal, generally it remains constant, and choline is abnormally elevated, and choline plays a very significant role in diagnosis of malignancy, non-malignancy, and grading also. Higher choline, higher chances of higher grades of malignancy. And lipid lactates are elevated in predominantly in necrotic tissues, and alanine is seen in meningiomas. And glutamate and this thing, you can see the resonant around 2.05 to 2.5. And 2-hydroxyglutarate, it is elevated in 2.25, and it is, we go a little deeper, IDH muted one will be elevated in this case, so that it gives a better prognostic values in the lower grade gliomas. So myoinositol is elevated in the lower grade gliomas, so the prognostic factor, it plays an important role in the lower grade gliomas. So this is little higher grades where choline and Na is reversed. It is more than 2.5 to 5 ratio. And this is to show grades and other variants of oligodendromeningioma, that resonance levels and comparison. And this is to show the grading of stages, various stages of hemorrhages within the tumor or a lesion. And we try to make out cystic, hemorrhagic, necrotic and internal vascularity, and calcification and perilesional edema of the tumor substances. So coming to the intracranial tumors, so extra and intracranial tumors, predominantly I talk about more of a meningioma. And meningioma we classify into this thing, histological type based on the MR images also. Like our success rate of picking up is around 80 to 90%. And just to show this image, you can see there is a lesion in the left Sylvian fissure, and you can see there is a heterogeneous signal on T2, and which appears blooming on SWA. So this is a straightforward case of a pseudomatous meningioma. On histopathological sections, you can see the abundant pseudomatous calcific bodies within. And this is another meningioma seen arising from the Sylvian fissures with heterogeneous signal intensities, predominantly hyper. And you can see it is typical of a meningothelial meningioma. And you can see that meningothelial cells, abundant meningothelial cells on the histopath images. And this is, you can see this is a hard mass on MRI, and you can see the enhancement pattern, and hyper on T1, and it is, you can see there is a areas of hemorrhage and a little bit of calcific foci. Suggestive of a hard mass, we guide neurosurgeons to say that there is a hard mass, and you can see it is infiltrating into the transverse sinus also. And this is the same image. And you can see that meningothelial cells in the histopath and fibrous, spindle-shaped fibrous fibroblast within. And this is a straightforward case of a small microcystic areas within the extraaxial mass. And you can see that this thing, sometimes it is confusing with angiomatous meningiomas because that has more signal voids. So in this case, you can see the cystic cystic areas with meningothelial cells. This is typical of microcystic meningioma. And you can see there is a signal voids within the lesion and extensive edema. So extensive edema, we always think about angiomatous or a secretory meningiomas. In this case, you can see there is a vessels, you can see the vessels within, and meningothelial cells and scattered all around. So this is typical angiomatous meningioma. And this is to show there is a end plague meningioma. You can see the thickening of the dura in the posterior occipital region. And this is another case where you can see the end plague meningioma as well as pseudomatous meningioma in the same patient, recently done case. And this image on the top A shows more a fatty content and which appears bright on T1 and fat suppressed on FS sequence, which is on the D, suggestive of lymphomatous meningioma arising from the sphenoid wing. So this is secretory meningioma. You can see there is a heterogeneous signals and vascularity is around and extensive edema. Any extensive edema, we always think about atypical meningioma or a secretory meningioma. So this is the image on the top, shows the meningothelial cells and vascular and secretory glands within. And this is a meningioma mimics. You can see the mass coming from the cellular region. In the coronal image, you can see a tumor arising from the cella with engulfing the vessels but not significantly displacing the substance. That is suggestive of a soft tumor, suggestive of macroadenoma. And you can see the enhancement here and you can see the hemorrhage. So this is a hemorrhagic macroadenoma. And this is to show the glandular histopath images. And this is another intracellular tumor with sphenoidal extension. And this is another case where we initially thought it is a meningioma. You can see the enhancement with central non-enhancing areas. We thought it is, we can see the dural tile also. And dural tile. So we thought it is a meningioma, straightforward meningioma with extensive edema. So we thought it is more to do with meningioma. But after post-op, it tended to be a this neurocysticercosis. And this is the case. We can see there is a mass with ISC extension, a typical ice cream cone appearance, suggestive of a schwannoma. You can see that histopath confirmation of the same. Coming to intraaxial tumors, there is an image which initially we thought it is a granuloma. Follow-up after 2-3 months, it showed extensive involvement more and central necrosis. Then CT showed little bit of speck of calcifications, suggestive of oligodendro. So our success rate of picking up oligodendro is almost 100%. And this is a case, you can see there is a periventricular enhancing lesions, predominantly perivascular involvement with extensive edema, typical case of a lymphoma. So generally we see this type of lesion as a primary CNS lymphomas. And you can see this histopath with lymphoid tissues, extensive lymphoid tissues within. And initially we thought it is like small lesions within the subcortical and deep hemispheric white matter. And you can see the extensive edema, and it shows heterogeneous enhancement. And so we made a diagnosis tuberculosis. After a course of ATT, patient responded well, and patient went happy without surgery. So this is another meningioma-like appearance, but it tended to be an atypical teratoid rhabdoid tumor. And you can see that you can see this mass with teratoid cells. And you can see the extensive edema in T2, but with post-contrast it exhibits heterogeneous enhancement and typically of CA lung metastasis. And coming to the lower grade intracranial tumors like pilocytic astrocytoma, you can see the cystic with solid component and little bit of perilesional edema. So it is a typical of pilocytic astrocytoma. You can see that images, asteroids and other cystic components within, typical of lower grade gliomas. And you can see the extensive involvement of cortical and subcortical and deep hemispheric white matter involvement. So it is, you can, based on this, you can say that this is an extensive higher grade tumor, likely anaplastic astrocytoma. And this is another image. You can see the peripheral enhancement with central necrosis, suggestive of with hemorrhagic foci within, suggestive of GBM. Coming to the METs, there is a typical location for some of the METs like RCC. The metastasis predominantly in the coracoid plexus and extensive network of metastasis in the coracoid plexus. And this is that mucinous carcinoma metastasis typically in the middle cerebellar peduncles. And this image edema, you can see the edema of both hippocampus and optic optic nerves and this thing. This suggestive of limbic encephalitis, sequelae of a paraneoplastic syndromes. And this is it is looking like a mass, but it is not a mass, it is just an artifact. And see that this is a wraparound artifact. And coming to this thing, advances, MR microscopy is the future, where we can zoom up to the 1,000th of times of the images, and we can pick up micro metastasis in future. And future MR reporting will be at cortical layers. That is, maybe within 10 to 15 years time, we will be reporting cortex 1 as this lesion, cortex 2 layer as this lesions. So, and my reference are this, and I thank you for giving opportunity. Thank you.
Thank you for the interesting session, sir. The black and white images of MRI in fact added more colors to this conclave. Now I would request Shri Radha Krishna Garu sir to present the memento to Dr. Vinod sir.
Thank you, sir. Now I request Dr. Anil Babu, sir, consultant neuro anesthetist and neurointensivist, and also had done fellowship in ECMO, to address the stage and present the talk on the critical role of neurocritical care in modern medicine.
Chandu. Good evening, all. Yeah. Thanks for the patience from the audience. So I'll conclude this with a short talk. Mostly I'll try to cut down and I'll try to show what is important. Yeah, thanks. So today I'm here to discuss about our neurocritical care work for the last 1 year. It's all about balancing the cerebral and other systemic therapy priorities, because the whatever we do for brain, it can be a troublesome for other organs. Like if we are preferring high PEEP strategies for ARDS, that can cause actually a raised ICP. So, and even the mean arterial pressure augmentation, what we follow in certain conditions of neuroemergencies like subarachnoid hemorrhage, which is thick, causing vasospasm and thereby causing delayed cerebral ischemia. So this MAP augmentation is a treatment of choice, but these patients at the same time they can have a strain on the heart, and even the hyperosmolar therapy what we use in routine, they can be a burden to the kidneys, and even the anticoagulation strategies can have a bleed risk, and even if in CSVT, even if there is a thrombosis, we prefer to give anticoagulants. Even the sedation has to be titrated so that the neurological examination shouldn't be affected. So we follow the multidisciplinary interface from all the other teams like emergency medicine, radiology, and the other branches. So what makes neurocritical care unique? Why this is unique? So brain is a unique organ where it draws more than 10 times of the oxygen when we compare to its weight. So brain has a weight of 2% of the body weight, and it draws the oxygen, 20% of the oxygen. So there we can understand that brain has a substrate only, it's the only innate substrate is glucose, and even it cannot tolerate a minimum time of hypoxia. So we can say like brain has a cerebral autoregulation where it maintains a constant blood flow even if there is a fluctuations in the perfusion pressure. But in all the neuroemergencies like meningitis, SAH, ICH and acute ischemic stroke, this autoregulation is hampered. So any systemic change in pressures will have a direct impact on the brain, thereby having outcomes worsening. So the outcomes can be improved by frequent neurological examination, which is the real-time monitoring and most accurate compared to any other imaging or any other modalities. And we target usually ICP, CPP, PaCO2, as these can affect the cerebral autoregulation and cerebral blood flow. So it has coupling called cerebral coupling, so where the metabolism can increase the cerebral blood flow. And sometimes even interventions can be done at the bedside for a code brain. Code brain is a condition where the brain is herniating And at that point of time, even a simple EVD insertion can be a life-saving. And I'm not going to talk about the entire neurocritical care. I'll just tell about the BP targets in various neuroemergencies. If you come to acute ischemic stroke, if you are planning to thrombolize, then before thrombolysis, the BP has to be like 185 by 110. And after thrombolysis, it has to be like less than 180 by 105. And if you are not thrombolizing, then even we can wait up to 210 by 120. And in ICH patient, we usually target a BP of less than 140 systolic blood pressure. And when it comes to TBI, the Brain Trauma Foundation guidelines, they suggest based on the age group. For young patients up to 50 years, the systolic blood pressure has to be maintained more than 110. Even a single episode of hypotension can cause a detrimental mortality outcome in such patients. So maintaining perfusion all the time in TBI is very crucial for the outcome. And even we give induced hypertension with the support of inotropes in a case of subarachnoid hemorrhage with impending delayed cerebral ischemia to maintain the perfusion. So what I mean to say, so we are allowing higher pressures in neurocritical care, and usually we don't do this for other scenarios. So this is another important thing which I want all of you to know. So it is called managing refractory intracranial pressure with 4 tiers of therapy. First one is a 0 tier, and then tier 1, tier 2, and tier 3. So you can see all the modalities in the slide. So what do we monitor in addition to the regular monitoring? In addition to regular monitoring like invasive blood pressure, saturation, ABG, ECG, ETCO2, we also monitor the brain electrical activity and brain cerebral blood flow, brain metabolism, and non-invasively we can calculate the intracranial pressure and compliance of the brain. So what do we target? The whole neurocritical care lies on managing and avoiding the secondary brain damage. So whatever damage happened, which is called primary damage, is irreversible due to the neuronal cell death. So whatever we do in our ICU, it is to prevent the secondary neuronal damage and to reduce the cerebral metabolism and to assess the blood flow velocities to make sure that cerebral perfusion is maintaining. So this is the latest non-invasive techniques to maintain the ICP and to monitor the cerebral oxygenation and to monitor the cerebral autoregulation and cerebral metabolism. So most of the tests we have at our institute. So except that B4C, which is not yet introduced to our country. So B4C is we can non-invasively monitor the ICP with the help of ICP waveforms. So electrical monitoring, this is just a glimpse of tests with which we can monitor the patient brain electrical activity. EEG, SSEP, BAEP, BEP, EMG, and bispectral index. So EEG, which Dr. Vijay has explained. So we have 24/7 EEG, continuous EEG monitoring at our hospital along with video EEG. So this is bispectral index with which we can assess the patient depth of anesthesia, and in status epilepticus we have to monitor and we have to maintain a burst suppression, and with the help of bispectral index we can maintain that. So for assessing the global cerebral blood flow, there are a few tests. First one is a transcranial Doppler, which we have at our institute. So with this we can non-invasively calculate the intracranial pressure, and based on that we can calculate the cerebral perfusion pressure, and without shifting the patient to CT, we can titrate the therapies, like we can reduce the 3% saline or we can increase the mannitol without causing systemic side effects. So if you give 3% saline, it can rapidly changes the sodium levels, which can have its own complications. So by doing serial TCD monitoring and all, we can reduce the patient transport for CT and we can take decision on bedside. So here are the 4 windows which we usually do. So So these are the TCD findings for our SAH case. So in the last slide you can see the cerebral vasospasm. So other than cerebral vasospasm, we can use TCD for ongoing embolization detection and even for knowing the patient impending cerebrocirculatory arrest in impending brain death cases where ethical issues are at stake. So this is jugular venous oximetry. So the overall monitoring and all, it all depends on maintaining the basic physiology like delivery of oxygen, cerebral metabolic rate, aorto-jugular differentiation of oxygenation and cerebral metabolism. So here the useful slide, it is useful for residents. So if there is an increase in ICP, then we have to what to do and all. So NIRS, it is in the pipeline. We are getting this. This is basically cerebral oximetry. Non-invasively, we can assess the cerebral oxygenation. It is basically a regional cerebral oxygenation monitoring device. Other than this, we have SJVO2 monitoring, where it gives a global cerebral perfusion or oxygenation. So this is a cerebral microdialysis, which we don't have, which usually only AIMS has this for research purposes because it gives a real-time ongoing changes in the biochemistry inside the brain, and it is usually invasive. So here I just conclude this talk with few testimonials. So Dr. Anand sir has explained this, and this is a case who was presented to Amara with, one second, listen to him.
I would like to thank you, Dr. Dr. Ramadevi ma'am, expressing my gratitude for the special care for me provided during my treatment for a brain tumor, and special thanks to Sai Anna to do my
Volume 100.
Good afternoon to all doctors and staff members. I would like to thank you, Dr. Reddy sir, Dr. Ramadevi ma'am, expressing my deepest gratitude for the special care for me provided during my treatment for a brain tumor, and special thanks to Sai Anna to took my special care for me. Now I am living to a healthy life and healthy studying well. Thank you for all supporters and Amara Hospital's management and staff members.
So he got admitted with encephalitis. He was in coma for more than 1 week. Just we have monitored the whole week with the help of TCD. As we were seeing an adequate normal perfusion, we were very confident that he would come out. So finally he came out, and now he is doing his job, and he is from Gajalamandyam. Yeah. And then the next case. So here, see, this is one more interesting case. A 19-year young female who was brought to Amara, and even one leading newspaper has mentioned that patient is died on the railway track. And we have received her, and she was operated, and she was ventilated, and she stayed here for more than 10 days. And finally, it is she.
నార్మల్గా న్యూస్ పేపర్లో వచ్చేసి నేను చనిపోయాను అని చెప్పారు. థ్యాంక్స్ లాట్ అమరా హాస్పిటల్ మేము ఉన్నాం అని ముందుకు వచ్చారు. ఫస్ట్ దానికి హ్యాట్స్ ఆఫ్. నాకు ఇప్పుడు హెల్త్ చాలా బాగుంది. నాకు ఆపరేషన్ ఎస్పెషల్లీ ఆనంద్ సార్ అండ్ యశ్వంత్ సార్ నాకు ఇంత మంచిగా రికవర్ అయ్యేదానికి వాళ్ళిద్దరూ ముందుకు వచ్చి నాకు ఆపరేషన్ చేశారు. అక్కడ వర్కింగ్ అండ్ నాన్ వర్కింగ్ పర్సన్స్ కూడా నన్ను మంచిగా చూసుకున్నారు. థ్యాంక్స్ అలాట్.
Yeah, and here one more case, severe head injury. He was a police. He was got hit by some red sandal something. So he was brought to us with a poor GCS, and he was surgery done, and then he had a long course in our ICU. He was tracheostomized, ventilated, and then we have weaned from the mechanical ventilatory support, and then even rehab has been started here. So what we believe is early recovery or rehab services should start in the ER, should start in the ICU by preventing the early delirium, and by doing early mobilization.
ఏం పేరు? ఎక్కడి నుండి వచ్చావు ఇప్పుడు?
బెంగళూరు నుండి వచ్చాను సార్. బెంగళూరులో ఉన్నాం సార్. ఇక్కడ దీంట్లోనే ఉన్నప్పుడు చాలా సీరియస్ ఉందంటే ఇక్కడ అక్కడికి వెళ్ళి
So again, he has rejoined in police services, but into a clerical side, where he has just book work. And this is one more interesting case, severe head injury, and the same scenario like the previous case. Eventually, we have decannulated, and she was talking even before discharge. And this is an interesting case of myasthenia crisis. So myasthenia gravis and crisis, we differentiate when patient has respiratory failure. This patient had ocular symptoms along with that respiratory weakness. He was also, we have given IVIG and all the other treatment modalities. And finally, he is recovered and he is doing his software job.
Good morning. Myself, Taru. నాకు నర్వ్స్ ప్రాబ్లం వల్ల కాళ్ళు చేతులు పనిచేయకుండా అయిపోయింది, నోట్లో మాటలు కూడా పడిపోయింది, కళ్ళు కూడా నాకు విజన్ సరిగా లేకుండా అయిపోయింది, ఆల్మోస్ట్ కళ్ళు తెచ్చేప్పుడు కాని పరిస్థితి. ఇంకా మేము చాలా కష్టమేమో అనుకున్నాం, హెల్త్ ఏమి ఇట్లా అయిపోయింది అనేసి అని. ఇప్పుడు అమర్ హాస్పిటల్లో జాయిన్ అయ్యాము. అక్కడ న్యూరాలజీ డిపార్ట్మెంట్ విజేందర్ రెడ్డి సారు, అనిల్ సారు నన్ను చాలా బాగా చూసుకున్నారు. అండ్ బెస్ట్ మెడిసిన్స్ నాకు సప్లై చేశారు. అండ్ స్టాఫ్ అండ్ క్లినిక్ డిపార్ట్మెంట్ వాళ్ళు కూడా నన్ను బాగా చూసుకున్నారు. దానివల్ల నేను ఇంత ఫాస్ట్గా రికవర్ అయ్యి మేము ముందుకున్నాను. థ్యాంక్స్ టు అమర్ హాస్పిటల్ అండ్ విజేందర్ రెడ్డి సార్ అండ్ అనిల్ సార్ అండ్ clinic management.
Yes. And one more head injury, bad head injury. He was brought to with a GCS of E1 VT M1, and finally, this is his status. Even he was tracheostomized and decannulated, and rehab care. He was actually referred to a rehab center, and where the rehab care was given. So this is the pic. He came here for decannulation. So this is one more interesting case, a case of CSVT with malignant MCA stroke, with malignant cerebral edema requiring a decompressive craniectomy. So this is Vedavyasal Naidu. We have taken consent from all our testimonial cases. So this is a case of diffuse axonal injury where it takes more than weeks or months for patients to recover. So this patient is managed conservatively without any surgery. So this is our very own he is a perfusionist brother. So he got admitted here with posterior circulatory stroke, with impending, with minimal hydrocephalus and with brainstem compression. He was managed medically, and without any requirement of surgery, he got discharged. And this is one more case of septic abortion with malignant MCA stroke. And this is a complicated case of pituitary adenoma, and she has been referred to here from various hospitals, because in view of her other comorbidities, nobody has suggested surgery and even tried. So we have done, and she got discharged without any issues. And this is our team, our heroes of neurosurgical or neurosciences ICU. And our strengths, as said by Prasad sir, we have all the latest equipment like ROTEM. So this is a peculiar test where we can use for polytrauma patients, as this hospital is a tertiary trauma center. So we can use ROTEM to reduce the unnecessary blood transfusions. So we can get the test within 5 to 10 minutes, and we can differentiate what product to be given, whether it is fibrinogen or cryoprecipitate or SDP. So with the help of ROTEM, we can decide on that, and we can unnecessarily avoid the blood transfusions, thereby having other complications like trally, TACO. And we have ECMO facility also. We have done ECMO for 2 cases with some good outcomes. And we have 24/7 blood bank services and thing. So we are capable of managing all the polytrauma and complicated cases. So this is other neuro gadgets which we use for our neurosurgery. One is neuro navigation and the other one is microscope. So conclusion is timely and early intervention can save lives and brains. Thank you. Yes.
Thank you, sir. Thank you for the valuable insights. Now I request Dr. Shivbharati ma'am to present the memento to Dr. Anil sir. Thank you, sir. Having successfully completed the scientific talk session, now we have Dr. Hemant Kumar, sir, consultant cardiac anesthetist and critical care, to talk on achievements and metrics of neurosciences at Amara Hospital. Please welcome, sir.
Good evening, everyone. I'm Dr. Hemant Kumar, cardiac anesthetist. On behalf of Neurosciences Department, I'm presenting the activity report covering from February 2024 to June 2025. I begin with case volumes and I compare our key quality metrics with the international benchmarks. Over 16 months, we had taken 68 patients into the neuro ICU. The average mortality rate is 1.7%, and no mortality is due to the sepsis. Healthcare associated infections, VAP, CAR-T, CLAPC, ventriculostomy infections, DVT, pressure source, unplanned extubations are well below the benchmarks. Coming to the most important quality indicator, mortality rate, the dotted line above represents the benchmark of neuro ICU, which is 10% according to Neurocritical Care Society. So our outcomes are less than 1/4 of the accepted benchmarks. So our best outcomes are possible because of rigorous and multidisciplinary rounds by neurologist, neurosurgeon and neurointensivist, and trained staff, strict adherence to evidence-based protocols, nurse-staff ratio. So over 16 months, completed 525 neurosurgical procedures. Majority are traumatic brain injury. On more complex side, they have done aneurysmal clippings, pituitary tumors, CP angle tumors, tumor excisions, and microvascular decompression of terminal neuralgia, and spine surgeries. This is the snapshot of outpatient and inpatient diagnostic volumes. Neurosurgery OPD 3,500, neurology OPD 13,443, neurosurgery IP 662, neurology IP 955. Total number of procedures EEG, nerve conduction studies, electromyography, visual aortic potential 729. Thank you.
Thank you, Dr. Hemant, sir, for updating us about the achievements of the Department of Neurosciences at Amara Hospital. I would now request Shivram Krishna, sir, HOD, ER Department, to hand over the memento to Dr. Hemant, sir. Thank you, sir. I would now welcome Dr. Shankar, sir, HOD of Critical Care Medicine, Amara Hospital, to present vote of thanks and lead memento distribution to the organizing team. We welcome you, sir.
Good evening, everyone. I think all of you enjoyed our neuroscience conclave. So, on behalf of Amara Hospital and organizing committee, I take this opportunity to extend my heartfelt gratitude for the success of today's neuroscience program. We are deeply honored by the presence of our chief patron, our respected chairman, Dr. Varaprasad Gourineni Garu, our managing director, Dr. Ramadevi Gourineni Garu, whose vision and constant support inspire us to achieve greater heights. I also extend my sincere thanks to our chief operating officer, Mrs. Bhagyalakshmi Garu, for her continued support and guidance throughout the program. I extend my sincere thanks to our distinguished chief guest, Mr. Radhakrishna Garu, Joint Director, ESIC, Rayalaseema Zone, Dr. R.R. Reddy Garu, President, IMA, Tirupati, Dr. Sudhakar Reddy Garu, Senior Neurosurgeon, for gracing this occasion despite their busy schedules. A special word of appreciation goes to our neuroscience head and neurosurgeon, Dr. V.K. Anand sir, whose leadership, vision and constant guidance have been the cornerstone for this program success. Dr. Anand and his team's commitment to advancing neuroscience at Amara Hospital continues to inspire us all. I would also thank and I would like to express my gratitude to our neuroscience faculty, Dr. Yashwant Sandeep, our neurosurgeon, Dr. Vijayendra, our neurologist, Dr. Anil, our neurointensivist, Dr. Vinod Sharan sir, our senior radiologist, Dr. Radhika, our senior intensivist, Dr. Rakesh, our anesthetist, Dr. Hemant, our cardiac anesthetist for their valuable contribution for this program. A special thanks to our emergency department led by Dr. Shivaram Krishna for standing by with their expertise and readiness and ensuring the highest level of care 24/7. A special thank to our talented anchors Dr. Hita, Dr. Venkatesh for hosting this program so professionally and keeping the spirit of the event alive. My heartfelt thanks to the organizing team, Dr. Vinod, Dr. Shivaramakrishna, Dr. Rajesh Naidu, Dr. Lalita Priya, Dr. Monisha, Dr. Vishal, Dr. Sai Kumar for their meticulous planning and seamless execution for this event, and all participants who made this event and very successful and meaningful. I also wish to acknowledge and thank our other administrative staff and marketing team, Vijay Shankar Garu, Kamakshay Garu, Sridhar Garu, Saraswati Garu, Shilpa Sri Garu, Sai Chandu Garu, and other technical staff for their behind the scenes work to ensure everything runs smoothly. I take this moment to sincerely thank our dedicated nurses, technicians and administrative staff, housekeeping staff, security staff and other supportive staff whose silent yet invaluable contributions have ensured that this program runs flawlessly. Lastly, I thank our institutional leadership and sponsors for their unwavering support in making this event possible. As we conclude, let us carry forward the learnings from today and continue to collaborate across disciplines for the better understanding and innovations in neuroscience. With this, we now move to memento distribution ceremony as a token of our appreciation. Thank you. I request Sita to announce mementos. After this memento distribution.
Our organizing team and marketing team have worked really hard to make this event a grand success. So let's honor them with a small token of gift, that is the memento. I would request Dr. Shankar sir to hand over memento to Shivaram Krishna sir. I would request Radhika ma'am to hand over memento to Dr. Lalita Priya ma'am. I would request Vinod sir to hand over memento to Dr. Vishal. Okay, Dr. Vishal isn't here. Okay, thank you. I would request Vinod sir to please hand over memento to Dr. Venkatesh.
Now I request Dr. Anil sir to present the memento to Hita ma'am. Now I request Dr. Rakesh sir to present the memento to Dr. Shankar sir.
I would now request Dr. Hemant sir to hand over memento to Vijay Shankar garu. I request Dr. Yashwant sir to hand over memento to Kamakshaya garu. I request Dr. Radhika ma'am to hand over memento to Saraswati garu. I request Dr. Vijayendra Reddy to hand over memento to Geeta Bhavani garu. I would request Dr. Rakesh sir to hand over memento to Dr. Ananta Kiran garu. I would request Sunita ma'am to hand over memento to Shilpa Shri garu. I would request Dr. Venkatesh to hand over memento to Sai Chandu garu. Sai Chandu garu.
I'm requesting Dr. Hita to hand over a memento to Dr. Namita. ఇంకా ఉన్నాయి. So I request Dr. Lalita to hand over a memento to Dr. Sunita. I request Dr. Yashwant Sandeep sir to hand over a memento to Dr. Anupama ma'am. Sir, we have our nursing staff, sir, 3 mementos. So they want, if you give the mementos to them, they'll be more happy, sir. Yes, sir. I request Dr. Prasad sir to hand over a memento to Chavi. And Mary, Neuro ICU in charge. Kirtana, Medical ICU. Vijay Nirmala from Cardiac ICU. Mr. Parshuram, OT in charge. Sir, Pensioners Association President Shankar Garu.
సార్ మేనేజ్మెంట్ అందరికీ మా యొక్క ఏపీ స్టేట్ గవర్నమెంట్ రిటైర్డ్ ఎంప్లాయీస్ అసోసియేషన్ ప్రెసిడెంట్గా నేను తిరుపతి యూనిట్లో 7,500 మంది ఉన్నారు. అట్లాగే తిరుపతి జిల్లాకు కూడా ప్రెసిడెంట్ నేనే ఉంటాను, టౌన్కు నేనే ప్రెసిడెంట్గా ఉంటాను. అమరా హాస్పిటల్ సేవా దృక్పథంతో ఏర్పాటైన హాస్పిటల్గా మేము భావిస్తున్నాం. మా సంఘానికి ఎనలేని సేవ చేస్తున్న అమరా హాస్పిటల్ వారి ధన్యవాదాలు. మాకు ఏ కార్యక్రమం అయినా సెకండ్ సాటర్డే ఎవరి మంత్ వచ్చి మన టీం మొత్తం వచ్చి మాకు సేవలో ప్రాధాన్యత కల్పిస్తున్నారు. ఈరోజు కార్డియాలజీ అంటే కార్డియాలజీ, మన దాని పేరు ఏమంటారు, ఏ డిపార్ట్మెంట్ కావాలని అది హేమకుమార్ వచ్చి మా దగ్గర ప్రతిరోజు అటెండ్ అయ్యి మా